Hello, hello, my friends. It is Jill Osborne from the Interstitial Cystitis Network. Yes, we made it another week. You never know in my home. Anyway, it is Sunday, March 5th. It is time for another live IC support group meeting. So, what is interstitial cystitis? Interstitial cystitis means that you have frequency, urgency, pressure, and for some of you, very severe pain in the absence of infection. It means that they don't know what's causing your symptoms. And an estimated 3 to 8 million women, 1 to 4 million men in the United States have symptoms of interstitial cystitis. Hello, Facebook. Hello, YouTube. And for many of us, our care has been non existent. You know, imagine, I remember my first year with IC, I had such severe pain. There were days when I couldn't sit down, I couldn't stand, I couldn't lay down. All I could do is pace. The, the pain of IC is rated equivalent to terminal cancer pain. It's agonizing. It is difficult to ignore. You know, if you were to cut your hand, yeah, it's going to hurt the first couple of hours. But then life goes on. You put a Band-Aid on it. It slowly gets a scab. You're good. The bladder pain's very different. That C fiber pain nerve in the bladder, it is hard for that to get turned on, but once it gets turned on, it's hard to get it turned off. And so bladder pain is relentless. It is difficult to ignore. It pounds away at you. And that's why so many IC patients are struggling to find care, because here's a harsh reality. Hello, Di from Hawaii. What island are you on, hon? Doctors are still treating interstitial cystitis out of old textbooks. We're not doing that anymore. Today, we are no longer saying, hey, you've got this incurable bladder disease. Here's some Elmeron. Here's the diet. I'll see you in 6 months. We're not supposed to be doing that anymore. Instead, we're trying to figure out what's causing your symptoms. So the way we do that is with phenotyping or subtyping. Hello, Caroline from England, and Di is from Oahu. I have a family on Oahu, and my aunt and uncle lived up in the Manoa Valley. And you know, my favorite ever place on Oahu was Paradise Park, which is now closed. It's up at the end of the Manoa Valley. Hello, Debbie from Southern Alabama. It's hot. Oh, we just had a massive hailstorm. It's cold here. It's very cold here. So anyway, when you struggle with bladder pain and when you struggle with pain, I mean, it's not like it's your shoulder. It's not like you can go, yeah, it hurts right here and get immediate sympathy from everybody. They can't see it. Your doctor can't see it. It's very difficult to understand why pelvic pain occurs. And there are lots and lots of different things. But here's the other thing that happens. So here, I mean, this happened to me. Like, I'm in agony, right? My bladder is screaming at me. I go to my urologist. I have a cystoscopy. My cystoscopy is normal. And you're like going, you're laying there with your feet in the stirrups. And the doctor goes, well, Jill, I don't see anything. I'm in pain right now. And they go, no, you have a completely normal bladder. And of course, this creates this really weird emotional response, because then we start thinking, is it real? Some of you have done this because I've talked to you. Hello, Amanda from Nova Scotia. Nice to meet you. So we start doubting ourselves. Our doctor starts rolling their eyes. Well, Jill, I don't see anything. So I don't know what to tell you, but I don't see anything to treat. And you're literally laying on the table crying. I remember in high school, I had really severe vulvodynia. I couldn't wear underwear, I couldn't wear jeans. It was very difficult. We're feeling like somebody had taken a sandpaper and rubbed off all the skin down below me, down below. I'd go to the gynecologist again crying. What is this? He goes, Jill, you're normal. I see nothing wrong with your skin. You just have the most sensitive skin I've ever seen in my life. That was his answer. You have the most sensitive skin. I've ever seen in my life. Well, there's a good happy ending here. There's a very, very good happy ending. Hello, PK. Hi, Deborah. The happy ending is we now know why it was hurting so badly. And yes, some of us really do have normal bladders. Why did I have vulvodynia? Because my muscles were tight. My muscles were so tight, they were squeezing the blood vessels going to my vulva. They were going to my urethra, going to my bladder. Yes, I physically had a normal bladder wall. I did. I totally get it. Now we look beyond the bladder. So if you ever have a doctor say, hey, yeah, I don't see anything wrong with your bladder, that's great. Don't take that as being doubted. That's like fantastic. If you see nothing physically wrong with my bladder, then what we're going to do is we're going to look beyond the bladder. Let's look beyond the bladder here. What else can be triggering some of these symptoms? And that's exactly where IC is right now. It's fantastic. We are at such a great place right now because we can now find underlying causation. And I love talking with you guys on the phone. I love talking with you on the phone because we get to kind of re-roll the inner dialogue. We get to say, oh, infection. They found no infection, even with next generation DNA urine testing, no infection. You think it's Hunner's lesions? Well, let's look in the bladder. Nope, your bladder's healthy. It's not your bladder. It's something beyond your bladder. But Jill, I've taken antibiotics for years. They always work. Well, the reason why you feel better is because they have an anti-inflammatory effect. But that doesn't mean you have active infection. Now let's look beyond. And so many of you, when we start going through some of the other symptoms like tight pelvic floor muscles, hey, when you go to urinate, can you start your stream right away or do you hesitate 5, 10, 15, 20 seconds? Oh, okay, yeah, I can't start my stream right away. I literally sit there for 10, 15 seconds before I can relax. Okay, that's your muscles. Okay, when is your pain the worst? Before you pee? This to you. Hold on. Where is it? Is that it? Yeah, that's it. Today is a onesie day. I'm wearing a onesie because as Kayleen just said, it's a self-care Sunday. I'm being, see, I'll show you. Woohoo, onesie. A hot shot onesie from Free People. All right, so hold on. Let me grab a picture here real quick. Oh, where did I put them? No, it's not that one. It's not that one. It's not that one. PR slides. Is it in there? No. Where did my pictures go? Well, what did I do? Ah. Here they are. It had slid. Okay. So here's the important question. When is your pain the worst? Before you pee or after you're done peeing? Hi, Jennifer. I will get to your question in a quick second, okay? And welcome to the IC Network. Nice to meet you. Okay. Let us ponder this picture here for a moment. Let us ponder this picture for a moment. Consider this irritation or inflammation. And actually, you know what? I even have a better picture than that. Hold on. Let me get a better picture than that. Okay, this is a better picture. Okay. So when I ask you the question, when is your pain the worst? Before you pee or after you're done peeing? If your pain is worse before you pee, so as your bladder is filling with urine, you're feeling worse and worse and worse and worse until finally you have to urinate. You're in agony. And once you pee, you feel better. Okay? So if you think about the bladder for a moment, so imagine these are Hunner's lesions. So you have basically, some of you, only 5% of you have wounds on your bladder wall like these. So as your bladder is getting fuller and fuller and fuller and fuller and fuller and fuller with urine, urine is going into the wound and it hurts. it hurts. And then once you pee, bam, urine is no longer in the wound, you feel better. So if you have pain on bladder fill, that points us to your bladder. If you have pain after you're done urinating, that points us to your pelvic floor. Okay? And I was working with a patient this week. All of her pain was after she was done urinating. And she kept saying infection, 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 infection. It's like, honey, if it were infection and your bladder wall was compromised, you would have pain as your bladder filled. The fact that you have pain not on fill, but after fill is interesting. And I asked her, I said, well, does your pain ever change? She said, no. And then, again, sometimes talking to you guys is like trying to pull a needle out of a haystack, right? Because she's completely obsessed. She thinks it's infection this whole time. But then she goes, oh, but I do have symptoms of PGAD, persistent genital arousal disorder, where you feel this painful arousal sensation. And I went, okay, there you go. That's not your bladder. That's your pelvic floor squeezing a muscle, your pudendal nerve. That is a de facto proof you have tight pelvic floor muscles compromising nerves. And she's like, but it's my bladder. It's my bladder. It's my bladder. No, it's not. And she had a completely healthy bladder on cystoscopy, right? So the gift of where we are today is we're no longer going to condemn you to this quote unquote incurable bladder disease. We're going to try to find underlying causation to try to get you better, and in many cases healed. We want you healed. We want you cured. The problem with the word cure is it implies that there's a disease. And the only people that have a disease are these people. That's only 5 to 10% of you. The rest of us have a neuromuscular condition. And our new guidelines that were released last year by the American Urology Association absolutely say there's no disease happening in the vast majority of us. This is more neuromuscular injury or dysfunction that's affecting the bladder. Now, the exception to that is patients with estrogen atrophy. But estrogen atrophy isn't a disease either. But if your symptoms started after you went on birth control, if you've been on Lupron, if you've had a full hysterectomy, or if you're in your 40s, and I was working with a patient who was in her 30s who was going into perimenopause. Her mom went into full menopause like at 39. And she had all the symptoms of perimenopause in her like 36 or 37. And again, she's thinking infection, 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 bladder, bladder, bladder. And I'm like, no, no, no. Estrogen atrophy, quality and health of your skin. And as we go through some of these symptoms, and her doctor said, wow, you're really dry down here. Not a disease, just estrogen atrophy. That should give you comfort, right? That should give you comfort. So hold on a sec. Jennifer says, I'm new here. I had my gallbladder removed last Thursday. Couldn't urinate after. Had to get a cath and a leg bag. It's so painful. I have to stay in bed. Can't move around. I have IC. Holy moly, Jennifer. Gallbladder removals are not easy. It's kind of one of those things, one of those perfect examples where doctors kind of like minimize it. It's like, oh, you'll be fine. You'll be up and walking around in a week or so. Just like they kind of say that with hysterectomy. And one of the reasons why they say that is because they don't want you to assume it's not going to go well. Because your attitude, your anxiety and worry can contribute and make pain worse. So if they tell you, yeah, you're going to be bedbound for a couple of weeks, not necessarily helpful in the healing process. On the other hand, it's nice to have a clue, right? So having your gallbladder removed is tricky. My sister had hers removed. My mother had hers removed. And the whole thing about diet afterwards, eating afterwards can be really, really tricky. So my sister at this point in time can't eat anything with fat in it. My mother couldn't eat anything with fat for about 10 years, but now she can in smaller amounts. But, that's challenging. So the question, you had to get a catheter and a leg bag. So that means that they had to use really strong, heavy anesthesia, and it just numbed those nerves. Can you pee now, I hope? I hope you can pee now. You should be able to if it's been Friday, Saturday, Sunday, 3 days. Are you home? it was recommended that you wear to wear a catheter over the weekend to let the anesthesia wear off. So I'm ready to get it out. Do you think 3 days is long enough for the anesthesia to subside? It should be. It should. I mean, that's a really good question for your doctor. Obviously, I can't give you medical advice. My job is to try to give you context. I know that in my personal experience, the last time I had major surgery like that with very, very strong anesthesia, I could not pee for about 18 hours, but after that, it wore off. So I would hope that it would have worn off by now. Hello, Amanda from Nova Scotia. Oh, I already said hi. Yep, hold on. Facebook always moves my stuff up and down here. Debbie says, one thing I realized is the soap I was using when showering, I was using Dove. Then when it ran out, I went to a vintage bar of soap, and a few hours later, I got sharp pains that lasted about 2 hours. Now I don't use any soap in my vaginal area. I haven't had any more of those sharp pains. Could these be from harsh soaps that I was getting? Could it be from the harsh soaps? Yeah. I mean, especially if you're of a certain age and you have dry skin, absolutely. Dial, you want to talk how to kill your skin down there. It's something like Dial. Or one of my old boyfriends, I had flown back east to see him. And on my last night there, he made a bubble bath for me. I was watching TV. He came out. And he said, "Honey, I made a bubble bath for you." So I go into the bathroom. The bathtub's filled with bubbles. I look at the bottle of liquid Irish Spring, and I go, "Oh my God, this is bad." And I'm looking at that, and I'm looking at his face, and he's so proud of himself. And that smell coming off Irish Spring smells great, but if you're sensitive, it's like, woo. I'm looking at that. I'm looking at him. I'm looking at that. And he goes, "Oh, honey, just get in. It'll feel great." And I know I'm going to die, right? It's not going to be pretty. So it's like, okay, honey. So I literally gave in and sat in it for 5 minutes. I cried on the flight home, all the way home, from beginning to end. It was so bad. Oh my God, no pain meds, nothing. So yeah, soaps absolutely can trigger stuff. No doubt about that. Special also fabric softener, laundry detergent, mini pads that are scented, menstrual pads that are scented, any of those like that can really trigger those symptoms. Elke said, I had a hysterectomy in November for endometrial cancer. Girl, I have walked that walk. IC for 10 years, tried everything. My medical oncologist asked if I was in a car wreck. My latest CT showed a T12 injury. You got IC after an open thoracotomy for lung cancer. Wow. Wow. How are you doing? Do they feel like they got it all? I hope so. My diagnosis was complex endometrial hyperplasia with atypia and a vague architectural complex. So what that meant is that I had the atypical cells that convert to cancer, and they were in the process of converting to cancer when I had my hysterectomy. Hi, Diane. Barb saying, how am I? I am, I don't know. How am I today? I'm here. I'm functioning. I got all our taxes stuff done yesterday. That was my goal for the weekend. I feel pretty good, except I have a lot of residual pain from my bone graft up here still. If I talk a lot, like I'm wearing a flipper right now to try to protect the wound, and it still oozes every now and then. So I'm about 85% of normal, I would say. But I feel optimistic. I feel happy. I feel strong. I hope you guys do too. Anne said, do I have pain with IC? I used to have terrible pain with IC. I had terrible pain with IC. And I went without pain care for literally a year and a half. And then finally, I made the mistake of trying to I took a train ride up to Tahoe in the middle of all this, because my first diagnosis was a chemical cystitis, like chemotherapy cystitis. And I just needed to get away. My mom and I took the train up to Tahoe. Think about what that vibration did. I ended up in the hospital at Tahoe. My mom had to drive me home the next day. I was in the backseat of the car, writhing in pain, ended up at the hospital a couple of days in a row, and they finally gave me pain care. And it took about, I don't live with that pain anymore. I haven't had that severe pain in about 15 plus years. Why? Because we finally got to the underlying cause of the pain. The underlying cause of the pain was never really my bladder wall. It was really my pelvic floor. My muscles were just massively messed up. Amy says, I can't figure out what's going on. I had 6 months of feeling great, and all of a sudden I have pressure and pain when my bladder fills, and I still have it after I go. It also comes and goes, and it's different on different days. I'm just so scared. I don't know why this keeps happening. I don't want it to be something serious. I've had all the testing too. It's all been okay. So Amy, so listen, girl. Number one, this is great. You've had a lot of testing, and they've ruled a lot of stuff out. That's fantastic. So we can rule out infection. We can rule out a dysfunction with your bladder wall, right? Did they do a cystoscopy and look at your bladder? So now we have to try to, we're not going to follow those pathways anymore. We're going to look in a very different way. So the first thing we want to look at is your skin health. Are you in estrogen atrophy? And we want to look at muscles. We want to look at fibroid tumors. We want to look at pelvic congestion syndrome. There are lots of things that can mimic IC that are absolutely treatable. I feel like we should go into Zoom today so that you guys can actually share some of your stories. We haven't been in Zoom in quite a while. Facebook. The comments on Facebook keep going back. I can never stay ahead in reading these. So Amy, getting back to you, honey, if you ever want to talk, please feel free to give the IC Network a call. If you want to stick around, we can try to come back to you. And maybe what we can do is do a newly diagnosed coaching, and we can do it online so other people can see it and see kind of what we do. I'd be happy to try to do that. Oh, come on, Facebook. All right. Marianne says, I have a question. My urology nurse practitioner said I have a small bladder. My understanding is your bladder size does not change. So why was I able to hold my urine for hours previously? Well, because your bladder wall, in addition to having a mucosal layer, is muscle. It's muscle. Muscle fibers are like this. And so a healthy, normal muscle fiber feels like a chicken breast, a raw chicken breast. A tight muscle feels like beef jerky. And when muscles get tight, the fibers overlap. And then sometimes they lock down. They can lock down in a trigger point. And so when you have what we call a fibrotic bladder, it's not expanding in this way. There's a lot we don't know about exactly the biomechanics of how the bladder expands, but this is kind of the best example that I can give you. So why does the bladder become fibrotic? It can become fibrotic because of repeated UTIs, from scarring. If you've had laser therapy, anything that's put a scar in there, when you have a scar in there, that tissue gets stuck and it cannot expand like that. It cannot expand like that. Elke, hold that thought one sec. Hold that thought one sec. Shlomi said, what does the bacterial result in microgen test mean if I was diagnosed 10 years ago with IC with a hydrodistension? Well, 10 years ago, we thought that red spots on the bladder was IC. That's why the picture I showed you was kind of wrong, that first picture that I showed you. So a Hunner's, where did it go? A Hunner's lesion is, I've got so many pictures here. What's the best picture to show you? Okay, let's just use this one. So Hunner's lesions, right? These are big bloody wounds. So if you had, Shlomi, when you had your hydrodistension 10 years ago, if they found Hunner's lesions that look like this, big bloody wounds, they're known for bleeding profusely. They call it a bleeding waterfall. Okay, so if they found Hunner's lesions in your bladder, then that is absolutely a diagnosis of interstitial cystitis in the United States and Canada. And Europe and Canada. But here's the deal. Most IC patients actually didn't have Hunner's lesions. Only 5 to 10% of IC patients have Hunner's lesions. The rest of us on hydrodistension often had red dots. And so back in the 1950s, when they started seeing these, they thought that this was IC. They thought that this was some sort of disease, all these red spots. And so in 1987, when our National Institutes of Health created new diagnostic criteria for IC research studies, they said a patient could be admitted into the study if they have Hunner's lesions or if they have this. But then another researcher went, oh, not so fast. He took 50 women with no bladder symptoms who were scheduled to have a tubal ligation and said, can I please look in your bladder for research purposes? And they went, yes. And so they did a hydrodistension on normal women who were completely asymptomatic. And what happened? Bam, this. It turns out that petechial hemorrhaging or glomurulations are a byproduct of the test. That when you stretch the bladder, you break tissue and you cause these spots. So if you look at our new guidelines for IC, they absolutely have thrown this out as being meaningful in any way. So the finding of glomurulations or petechial hemorrhaging in the bladder is pointless. It's not reflective of IC. It's what happens when you stretch the bladder. Diane says, can you develop a fibrotic bladder if you had a lot of IC flares over many years? No, not really. I don't think so. I mean, if you're massively damaging your bladder chemically, I think that might be possible. So if you're drinking, like I was working with a patient on Friday who was drinking a massive amount of green tea, and green tea is very, very acidic. So if you keep pouring acid on the wound is going to get bigger and the wound might start scarring. So I think that maybe, but I don't think there's any research that proves that. Okay, Amy had a cystoscopy. Okay. Marianne said, what's the best treatment if you've had for your pelvic floor? Oh, by far, pelvic floor physical therapy and learning how to do it at home. I do it at home now. Amy says, I'm 37. They've checked for atrophy. I've had ultrasounds to check for fibroids. All of that is okay. Good. So Amy, tell us about your symptoms then. I want to know, number one, are you sleeping through the night? Number two, if you're having pain, where is the pain? Is it to the left? Is it to the right? Is it centered? Is it shallow? Is it deep? Is the pain on the inside or the pain on the outside? It's an interesting question. Jane said, my IC came on with menopause in 2017. Okay. Just starting vaginal estrogen. I have IC with 100 lesions. I have a very small bladder and pain only when it's filling and I need to empty at 4 ounces. Girl, wow. Is this estrogen atrophy? 2 weeks now on estrogen. Has this helped others to hold more urine? Is this a fibrotic bladder? You've never had a UTI. Oh, you're asking, I don't have an answer. I don't have the perfect answer for you, hon. This is what I can tell you, is that you have genitourinary syndrome of menopause and you've had it for 6 years. Thus, your bladder's ability to defend itself has been compromised for 6 years because you no longer have that nice thick coating of mucus on the inside of your bladder that normally protects the skin. That's a problem. Think about the bladder for a moment. It's the only organ in the human body designed to hold toxic waste because urine is body waste. Urine contains ammonia and urea and all sorts of irritants. So how can the bladder hold ammonia for hours at a time and not get damaged? Well, it turns out your bladder has a really thick, wet coating of mucus on the inside. And that mucus acts as a barrier. It prevents urine from reaching the cells and the nerves. It prevents bacteria from infecting your cell. Unfortunately, that mucosal layer is estrogen dependent. So when you're young and have lots of estrogen, you have lots of mucus. But if you're on birth control, if you're in perimenopause, if you had a hysterectomy, if you're of a certain age, bam, you don't have the estrogen anymore, which means you don't have the mucus anymore. You don't have as much mucus. Thus, your bladder's ability to defend itself is now compromised. We call this the genitourinary syndrome of menopause. It is not a disease. So we could potentially argue that your bladder was vulnerable and it was getting tweaked over and over again, perhaps by coffee or soda or something like that. And that it may have just started, it may have started. The best word I can think of is cringing, right? You've got a vulnerable bladder, you're pouring acid on it all day. What are those cells going to do? They're going to just kind of shrink in, maybe, kind of cringing back from the chemical irritant. That could be one potential explanation for why you might have a smaller bladder. Normally, what they would do is do something called a bladder holding protocol to try to increase your bladder capacity, to reteach these muscles how to slowly release and get back to a normal length, right? Bladder holding protocol. That's just time voiding. If you're peeing every 30 minutes, they basically say go to 35 minutes for a couple of days, go to 40 for a couple of days, go to 45 for a couple of days, and just slowly teach your bladder how to stretch out and relax again. Elkie, not quite yet. Elkie's asking if we can Zoom. I think today would be a good day to Zoom. It's just going to take me a couple of days to set it up, a couple of minutes to set it up. Diane says, when you say pain care, do you mean pain meds? Yeah. Sometimes you need pain meds. Sometimes, pain care is multimodal, right? So we don't just use pain medication. We want to try to figure out what's causing the problem. Like for me, my SI joint was really killing me a couple of days ago, and my muscles were doing this. I woke up and my muscles were doing this in my left hip, like that, like they were fluttering. Oh, it was awful. And so, and it was painful. So I had to put my SI belt on, and then I took a muscle relaxant to get the muscles to calm down. I did my stretches. And if necessary, I would have taken a little bit of pain meds if I had a little bit of pain meds. We don't just want to chase the pain. We want to figure out what's causing the pain and address that, right? Shlomi says, so the spots mean nothing. You're right. They mean nothing. She said, for years, I've said that this is IC. I know, we all thought that, but the new guidelines are very clear. It's not IC. It's not specific to IC. It happens to anybody who you stretch the bladder on. Okay, Amy says, oh, interesting, Amy. The pain feels like it's on my left labia towards the top, but sometimes it feels like it's centered to my bladder. It sometimes feels stabbing, sometimes feels achy, and it feels like it's inside. I just don't know how I could develop a bladder wall issue after eating and drinking okay all this time. Honey, the bladder is not going to cause pain on the left labia. What you're describing is nerve pain. You're describing nerve pain. That's classic nerve pain. That means that you might have a muscle that's now compromising the pudendal nerve that innervates the left labia. Bladder pain is never described that way. And yes, I know it feels centered to your bladder, but bladder pain is also not Bladder pain is very sharp and shrill. It feels like razor blades. So bladder pain doesn't usually feel achy. Muscles feel achy. Have you had a pelvic floor assessment? And also, Amy, do you have any symptoms of pins and needles, numbness, anything at all like that? Hey, Kayleen. I've been fishy about my physical therapist only doing lower back work. She's always asking about my bladder, but she hasn't been doing internal work. You know that my vulvodynia is getting worse and the vaginismus is bad. When I asked her about it, she said, I need to do the vaginal renewal program on my own. What? What? She's not doing any internal work at all? Now, she's not trained, hon. Internal work is the single most effective way, the single most effective way to treat tight pelvic floor muscles. Jane says, cringing is exactly what it looks like during a cystoscopy. There you go. Amy says, I'm just scared that since my cystoscopy last year, I've developed Hunner's or something neurological. Amy, Hunters don't develop that way. You were going to physical therapy for a while and then stopped because I was doing better. I was going again, but I'm 4 visits in and I haven't noticed anything yet. Okay, so Amy, do you ever have pins and needles? Do you ever have areas of numbness? Do you ever have a painful arousal sensation or pain by your clitoris? And when you went to physical therapy, what did they find on your first appointment? Did you have tight pelvic floor muscles? What'd they find? Marianne says, will treating tight pelvic floor muscles help with frequency? Absolutely. Kayleen said she only did the internal for the reassessment when my insurance started paying for another 24 weeks. Kayleen, that's ridiculous. That's absolutely ridiculous. She should be working internally every single day. Every single appointment, it's supposed to be internal when you have vaginismus and when you have tight pelvic floor muscles. I've never not had internal physical therapy visiting the physical therapist for pelvic pain. It's the go-to. I don't understand why she wouldn't do that. That is so weird. So normally when I do these meetings, I usually do a little 30-minute educational spiel, and then we take your questions. I did want to talk briefly about something. I saw a fantastic I love documentaries. I just love documentaries. It started with the brain football injury documentaries that addicted me to documentaries. So good. I love Frontline, which is a fantastic PBS show of documentaries. Also, Netflix does great documentaries. And there was one on UTIs caused by meat. And it was fascinating, absolutely fascinating. So you guys know that for those women and for some men, if you're diagnosed with a UTI or having these issues, there's often this incredibly embarrassing discussion about, honey, are you wiping okay? Remember, you're supposed to wipe from front to back, not back to front. And there's this whole impression that we're dirty. We're not capable of being healthy. I mean, of being clean and all this sort of stuff. And that's a whole nother discussion of this whole industry built about telling women that they're dirty and they need douches. No, we're not dirty. This is normal. The vagina is the single most it's clean part of your body because it's left soft skin every 5 hours. So this whole concept that women are dirty and that we need to clean ourselves with douches and stuff is ridiculous. And it's the same thing kind of happens with UTIs. There's like this impression, oh, honey, you're just dirty. You just haven't learned how to wipe yourself correctly, right? You know what I mean. It's happened. Well, so several years ago, there were a group of college students up in Washington, Oregon, and Idaho who got this really rare drug-resistant bladder infection. And it was a really bad infection, but it was very, very unusual. And it was only found in college students in Washington, Oregon, and Idaho. And they traced that infection back to a slaughterhouse and then back to a farm, a ranch that was massively overusing antibiotics. And when you use too many antibiotics, you create the perfect environment for a superbug to grow, a superbacteria to grow. So this concept of how are we getting our infections? Well, are we getting it from sex? Yeah, it's possible to get it from sex. But we are now very clearly understanding that some of our bladder infections are actually coming from food. So for example, a superbug is a bacteria that is resistant to most, if not all, antibiotics. Superbugs are terrifying for doctors because they don't have an antibiotic to treat it. So years ago, a superbug emerged in a small town in China, right next to this massive pork farm. And so these residents started getting this really weird bladder infection. They identified the infection. Then they found the superbug in pigs. All right. And farmers use a lot of antibiotics. Farmers use the vast majority of antibiotics that are made, right? Because they raise feeding animals in unhealthy conditions where they can easily get sick. So they give them a lot of antibiotics over time. So anyway, we have this massive superbug in China. Well, the superbug arrived in Europe. And then the superbug arrived in England. And then 6-7 years ago, a woman, I think like in Philadelphia, who had no travel history, she got the superbug. A superbug drug-resistant bladder infection. And it was identical to the one in China. And it's like, have you traveled? No, I have not traveled. So what did they do? They then started going through pork farms on the East Coast. What did they find? The superbug. The superbug had arrived here, and it was in the form of a urinary tract infection. And so this frontline documentary was specifically, can urinary tract infections be caused by animals? And the researchers, God, I wish I were in grad school again. My senior project in grad school was isolating drug-resistant bacteria. So there's a whole new group of researchers studying it. And they actually, and also in addition to UTI, also MRSA. MRSA infections, multiple resistant Staphylococcus aureus, right? Really devastating skin infections. So they took a map and they had a map of all the locations of people who had infection. And then they overwrote the map with all of the pork farms or all the farms. I think they were chicken farms in there too. And you could see superimposed over where these mass market meat producers were, you saw that this is exactly where the infections were occurring. And yet, of course, the food industry is denying it. They're saying, well, we don't have any proof that we gave a pig this antibiotic when they were 8 weeks old that now resulted in this person, Jill, getting a drug-resistant UTI 3 years later. So the meat industry is, saying, well, you haven't really established cause and effect. But it doesn't take a rocket scientist to see that there's an issue. So if you find that you do get a urinary tract infection, I just want you to know that, number one, it's not your fault. Number two, you're in all likelihood, you're not dirty. And number three, we're now really looking at food. So if you go to YouTube, go to Frontline, take a look at some of the documentaries there. They're absolutely fantastic. And something's going on YouTube because it said the chat disconnected. So that's all I'm going to say on that. So let's go back to your questions, and chat reconnected on YouTube. That's great. Okay, getting back to Amy. She said, I haven't noticed numbness or clitoral pain, sometimes burning. She says, I'm tight, but I always ask her if she's sure. I don't know why I doubt her. Well, does anything hurt when she does the internal pelvic floor work? That's important. Marianne says, funny, when I asked my physical therapist about the frequency, she said physical therapy wouldn't help my frequency. I'll tell you how it would, Marianne. It's all about ischemia. Ischemia is oxygen deprivation. So ISCHEMIA. So what is the long-term toll of having super tight muscles? The muscles squeeze the blood vessels. So if your bladder and your vulva is supposed to get 24 units of blood a day and it's only getting 10 units of blood a day, are you going to have a healthy bladder wall? Of course not. You would not. So ischemia in the pelvis can be devastating because it is now limiting blood supply to all of the organs, therefore causing quite a bit of the pain and discomfort that we're feeling. So therapeutically, when we restore blood supply through physical therapy and we get these muscles to relax, the bladder wall is now perfused with a lot of oxygen, a lot of nutrition, and the bladder wall should heal and calm down. And that's exactly why physical therapy would help bladder wall health. Sandy said, do you know what would cause pain in my urethra? I'm following a strict diet for IC. Well, number one, estrogen atrophy, hun. The very first thing we look at with urethral pain is estrogen atrophy. If you feel like there's a drop of urine stuck in your urethra that will not come out, that's a classic sign of dryness in your urethra. We would look at potentially infection. That's one of the ways we differentiate bladder wall injury versus bladder wall infection. Is infections are known for causing more urethral burning, whereas bladder wall injury is not known for causing a lot of urethral burning. We would look at infection of the periurethral gland halfway up the urethra. We would look at chemical sensitivity, and we would look at tight muscles because you've got muscles, your levator ani, that wrap around your urethra. So if those muscles are tight, you're gonna start having some urethral discomfort. So you're using an estrogen cream. Good. Are you putting the estrogen cream at the entrance to your urethra? That's what they had me do. Amy says it doesn't hurt terribly when she pokes around, maybe just feels tight, but she also said she thinks it's nerve related. Okay. But I just want it to get better. It has taken over all of my thoughts daily. You know, let me see if I can show you a picture. Here, hold on a sec. Let me see if I can show you a picture of that's not a very that picture you're not going to see. Let me see if I can find a better picture. Hold on, let me see. There's one picture in particular I think that you would find helpful. I just have to find it. Hold on. Ah, here we go. Okay, so hold on. Let me grab my model here. Okay. So Amy, let us ponder. I have to set this up. I have to set this picture up. So here's your pelvis. Hip to hip, we've got our pubic bone correct? Right here, right in front. And if we turn it around, we have got your vertebrae and we have your sacrum. Your sacrum is actually vestigial vertebrae that have now fused together. And you notice the 4 holes. So through these 4 holes emerge nerves, the pudendal nerve. It actually emerges in 4 sections, and then it merges in what we call the Alcock's canal, and then it splits up again to innervate the labia and the clitoris and everything, right? So all your nerves are going to start here. So let's look at it again from the inside. Okay, so you can see from the inside, the nerves are going to come out and enter the pelvic cavity here, okay? And I also want you to look at muscles. So the nerves are also going to eventually go through the muscle, and they go through the muscle via the Alcock's canal. Imagine it's like a tunnel. And then once they get through the muscle, they're going to come out here, and then they're going to innervate your labia and all that sort of stuff like that. Okay, so, okay. So here is a picture from the side of those nerves coming out of the sacrum. Do you see that? And they're merging right here. And then they're going through the Alcock's canal right here. And there we go. Then they're going to split up again down here. So that's from kind of that's kind of from the side. Now let's look at this picture. So you can see here the 4 nerves coming out. You see that? You got nerves coming out this side and nerves coming out this side. And then they're going to follow the front they're going to follow kind of the front by the pubic bone. And what you can't see here is that the nerves are right here on the left side and the right side. You got nerves that support your left labia, and you got nerves that support your right labia. So those are the nerves that she's talking about. Okay, those are the nerves that she's talking about. So if you've got a tight muscle, like I have habitually tight muscles on my left side. Why? Because my SI joint on my left side is screwed up. It's an old injury for me. And so my muscles on my left side are they get so tight, they quiver. I mean, it's like this. That's how my muscles were a couple of mornings ago. So about right before COVID, I had the weirdest sensation. Have you ever gotten a piece of pubic hair stuck in a zipper and you get this little pull? And you know exactly what it is, right? It's just a pull. It feels like a pubic hair is being pulled. So I had that happen a couple of times. And it's like, okay, you kind of adjust yourself, you kind of learn. Shaving is not necessarily good because when it all grows out, it gets very prickly, right? So you just kind of adjust your hair down there and hope it goes away. Well, it didn't go away for me. Then I started getting pins, and it felt like I was being poked by a needle in my left labia. And it started way up front. So I wasn't having any sensation directly inside my crotch. It was in my left labia. So I get a pinprick here, and then a pinprick here, and then a pinprick here. And then it kind of went to the right side too. And I'm like going, well, this is new. What the hell is this? And over a period, so I, do my normal self-care. It didn't work. And over a period of a week, it spread throughout my entire crotch from front to back. And it was just like a poke here and a poke here and a poke here and a poke here. It made no sense to me. So I go to, I do an urgent care appointment with my gynecologist. She wasn't there. I saw this elderly guy. He goes, well, Jill, you're bright red. Got to be yeast. He's scraped skin, like yeast. I think it's yeast. They put me on massive antifungals. Didn't work. Then I go to my regular gynecologist, and she's younger than me, and she's not particularly, anyway, she's not quite as good as my other one. She's like, no, it's eczema. You need steroids. Because basically my skin was absolutely bright red, like the shape of a mini pad, bright red. So I did the steroids for 2 months, and it's just getting worse, right? Pinprick, 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 pinprick. I was doing meetings. You guys probably saw me talk about it. So finally, I asked to talk with because I'm in Kaiser Permanente. I said, I would like to go to your pelvic pain specialist because this makes no sense to me. And so I had a virtual appointment with her, or an appointment on the phone. She went through my record. And she said, in the first minute, she goes, Jill, I know exactly what this is. And I'm like, what? She goes, it's a pudendal compression. You've compressed your nerve again. And I'm like, I had no idea that a pudendal compression can cause pin-like sensations in the vulva. And she's like, oh, no, we see it every day. That's a classic pudendal compression. Your muscles are tight. I need you to I'm sending you right back to physical therapy. I go right back to physical therapy, and the physical therapist goes, damn, you're tight. And then the other thing that she gave me is she gave me a compounded lidocaine estrogen jelly to use on the surface to calm the nerves on the surface. So I did physical therapy and I did the local anesthetic on the surface, and it went away. And occasionally, now I will say, about a month ago, I was walking and I started feeling that little pulling sensation again, but I knew what it was and I knew exactly what to do. And Amy says here, I do have a painful SI joint that comes and goes, so maybe that's connected. It is absolutely connected. Absolutely connected. Because your piriformis muscles are responsible for keeping that SI joint in place. And if your SI joint is moving like my SI joint is moving, then they're going to lock down tight. And if you allow that muscle compression to get worse and worse and worse, eventually proximal muscles are also going to get tight, and muscles around nerves are also going to get tight, and then you're going to start to see that pudendal nerve compression. You need this book, girl. You need this book. This is fascinating. This is the best book ever written, in my opinion, for our community. And listen, I think my book, I see 101's damn good. But for those of us who have muscle and nerve issues, this book is the bomb. It will teach you everything about where things are located. Because ideally, when you're getting physical therapy, I want you to be able to, as you're getting that physical therapy, visualize exactly what they're touching. What are they touching right now? Is it your piriformis? Is it your levator? Is it your obturator? You need to be that involved. I want to see if I can find you a success story. Hold on. Let me see if I can find a success story for you. So here, hold on a sec. So the pain is at the top of your left labia. That's exactly where my nerve compression was. Stabbing, achy, yeah. So again, I don't think that's a bladder issue at all for you. I think your physical therapist is right. I really think that it's a nerve compression. I can see if I can find a. There isn't a page in this book that is not. There are many obvious causes for pelvic floor injuries in childhood. These include athletic injuries, the repetitive trauma of chronic constipation, bicycle or horseback riding, ballet or gymnastics, sexual abuse, chronic emotional stress, any of which can ultimately be identified as the primary source of vulvodynia later in life. Well, anyway, let's see. As explained earlier, the vulvar tissues, particularly those in the vestibule and by the clitoris, are so abundantly endowed with delicate pudendal nerve fibers that they are the most sensitive tissues in a woman's body. When these delicate tissues are irritated, the nerve endings release pain-producing inflammatory agents that can create symptom flares in the short term and can sensitize the nervous system over time. This leads to a vicious pain cycle. It is therefore essential to protect the skin with a barrier ointment after first either soaking in warm water or gently cleansing. Oh, anyway, that's kind of off topic. But anyway, fantastic, fantastic, fantastic book. I can't recommend it more. All right, YouTube, I don't know what the heck's going on with you here. All right. You guys, when I'm looking here, I'm looking at YouTube. When I'm looking here, I'm looking at Facebook. The name of the book is Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. You can get it in the IC Network shop. It's $6 cheaper than on Amazon because I have a special deal with the publisher. Jerome Weiss, MD. This book is the bomb. Marlia says, I get a sensation on the inside of my right thigh that feels like a piece of toilet paper is hanging out of my butt and touching my inner thigh. I have even got a mirror out to look to try to pull the toilet paper out. There's no toilet here. What the heck? Honey, that's called a dermatome. So as nerves leave the spinal cord, every nerve goes to a specific location on the human body. And that location is called the dermatome. And the inside of the right thigh and the inside of the left thigh is a dermatome for nerves coming off of L4 or L5. I feel my right thigh feels like there's a tight belt around it all the time now. And that's because I have ruptured discs at L4, L5. I ruptured a disc there a couple of years ago during an evacuation. Sandy said, I have chronic irritable bowel syndrome with constipation and diarrhea. It will wreak havoc on my pelvic floor. Absolutely. Absolutely. So with irritable bowel syndrome, that's a common related condition to IC. So if you have IC, IBS, vulvodynia, fibromyalgia, TMJ, migraines, if you have two or more of those, your diagnosis is chronic overlapping pain conditions. And for those of us who are in this group, I'm in this group, we're going to focus on treatments for the central nervous system, that it's the central nervous system that's driving all of these pain conditions. Do you guys want to Zoom? Does anybody want to come into a Zoom meeting and tell their story and maybe get some one-on-one attention? We used to do Zooms at the last half of these meetings, and we haven't done it in a while because all the passwords and everything got messed up. But if you want, we could try to do a Zoom, but you have to tell me if anybody would come in. If not, that's okay too. I am here at your pleasure. Marlia said central nervous treatment is what? So, what the research has shown us for patients who have chronic overlapping pain conditions, Jeannie says, yeah, she would do a Zoom. Okay. So let me ask this question, and then I'll try to start up Zoom. You don't have Zoom, but we'd love to, but I'll give you a link. Okay, Becky, hold tight. So Marlia, one of the enduring questions in the chronic pain community is, why do some patients get multiple pain conditions? And about 10, 12 years ago, the allied patient groups got together and they started a research team called the Chronic Pain Research Alliance, and they are incredible, like the best thing ever. And so they brought experts from many, many fields, brought them together to try to figure out why patients struggle with multiple pain conditions. And their research led them to the central nervous system, and eventually it led them to the brain. And this is going to sound scary at first, but there's a very happy ending, so don't get freaked out because I'm in this group. What they consistently find in patients with multiple pain conditions is a brain stuck in fight or flight. The 24 hours a day, 7 days a week, our brain thinks our life is at stake. Normally, fight or flight only turns on, the sympathetic nervous system controls fight or flight. It only turns on when you're confronted with a stressor, a life-threatening stressor. So if I were to open my front door and see a fire raging towards my house, as I did 2 years ago, believe me, the sympathetic nervous system takes control. This is down at your brainstem. It takes control of the brain. It turns on the amygdala. It raises your heart rate. It raises your blood pressure. It tightens your muscles to prepare you to fight or flee, or to freeze, or to fawn. There are four different ones. Okay. So, but of course, so what do? Well, immediately when I saw fire, slammed the door, called the fire department, right? Fire department comes out. They put the fire out. The threat is gone. An hour later, the trucks are gone. The fire is out. I am safe. There is no reason for my brain to be in fight or flight. And it's at that point in time when the threat is gone that the parasympathetic nervous system retakes control of the brain. It lowers your heart rate, it lowers your blood pressure, and it relaxes your muscles. So fight or flight is very primitive. You can't think yourself in or out of it. This is hardwired in. When you sense a threat, your brainstem takes over and it controls your day. And it's really only supposed to be active during moments of intense stress. But what they found for patients with chronic overlapping pain conditions is it's on all the time. It's on all the time. Amy with Zoom, cool. Okay, let me finish this and I'll try to start up Zoom, okay? So, how do we know your brain is in fight or flight? Well, number one, anxiety disorder. Do you struggle with anxious thoughts? Do you struggle with anxiety? Do you struggle with catastrophizing? Most people with this, we're the no people. Hey, Jill, you want to go take a drive? No. Might hurt my bladder. Hey, you want to go out to eat? No. You want to go to a movie? No. Get COVID. You want to go? No. No. And I've asked a lot of doctors, why does my brain do that? Because I'm an extremely optimistic person. And the answer is that your brain is just in fight or flight. It's just trying to protect you because it thinks your life is at stake. And I'm not the no person anymore. I was a no person in my 20s and 30s. Okay. So therapeutically, well, and there's something else that we know. Patients who are in constant fight or flight, we have very sensitive skin. We have a wicked sense of smell. That smell is a brain function. So that tells us absolutely that our brain is working hard. So therapeutically, what we're going to do for patients with chronic overlapping pain conditions are techniques which disengage fight or flight. If we can get you out of fight or flight, everything calms down and pain levels will go down. But as long as you're struggling with anxious thought over and over and over again, you're going right back into fight or flight. So we do good sensory information. The way we turn fight or flight off is with good sensory information. We prove to your brain you're safe. and we're going to give your brain safe sensory information to get you out of there. Amy says that's also me. Okay, girl, see? Okay. So let's do, so this is what we're going to do. I'm going to go you through how to turn off fight or flight, the two-step process that we do there. And then I'm going to start Zoom. So for those of you who want to Zoom, hang tight. A lot of you probably have heard me talk about this all over again, the fight or flight stuff, but just hang tight, okay? And then I'll go ahead and try to start Zoom. Okay, Jennifer says, I have fight or flight every day. So did I. I had terrible anxiety disorder. And one of the questions that I have is, why did this happen to me? Why? While my friends were out getting married and having babies, I was laying in the fetal position in my bedroom or my bathroom with terrible cramps and massive anxiety. Why? That makes no sense. I wanted a normal life. You want a normal life. Marlia says nonstop too. So what the research has shown is that for those of us who have gone into fight or flight, there is a trauma. 80% of the kids who develop chronic overlapping pain conditions have a major physical trauma. Broken leg, they get hit by a car, or you were an athlete with a lot of falls, gymnastics, cheerleading, football. All it takes is 14 days of pain to put your brain into a constant state of fight or flight. And we call it a central nervous system maladaptation. It's not mental illness. It's not mental illness. It's nervous system injury. It's an injury to the central nervous system. And that injury can happen after a major physical trauma, like getting hit by a car or breaking a leg in childhood. I was working with one patient who had a broken back. Her mother didn't take her to the doctor for 3 weeks, sent her to school with a freaking broken back. She had massive chronic overlapping pain conditions as she got older because she was in pain for a very, very long time before they figured out what was wrong. Now, for the other 20%, there's a history of bullying or abuse. And the best way that I can explain this is, and I've talked to so many of you now, my story is very similar to many other people's stories. So whether you had an abuser in your home, whether you had an alcoholic at home, let's use that example. My parents were not alcoholics, thank God. My abuser was outside. Okay, but anyway, imagine having an abuser at home. Let's say a parent who's an alcoholic, and they hurt you every night when they get drunk. These are somebody who's very mean and very vicious, right? So for that child, school is your safe place. That when you go to school, you're safe. But when you get out of school and you walk home, you go back into fight or flight. And the closer you get to home, the worse it gets. You are extremely hypervigilant. You spend that night dancing carefully, trying not to trigger the parent to hurt you, right? In my case, I grew up in a neighborhood with a kid my age who became a rapist and murderer. And I was one of his earliest victims. I did not leave my home without fear from 4th grade through high school. The year I went away to college, he raped and murdered my neighbor. And when they called and told me that, I knew it would have been me if I'd been home. Right? So for me, home was my safe place. Being outside of my home was very, very scary. And it wasn't just, so we know 21 days of bullying or abuse will put your brain in a constant state of fight or flight. Well, I didn't have 21 days. I had years. I had freaking years of fight or flight. And when we have our high school reunions, we have our victim reunion because there are a lot of people who were hurt. And I just ran into one of my elementary school mates who was shot in the neck by him. You'd never know it. So when you grow up in that situation where you're just scared, it changes you. Okay. So that's why I ended up with severe anxiety is something happened and it was bad. And it was never my fault. A lot of us were hurt. But there's a very, very happy ending here because number one, he's doing life. He'll never be out again. Okay? Done over. And I'm an adult now. I'm not a kid. I don't have to worry about that happening. I know how to stop it from happening now. I will never, ever, ever let that happen to me again. Plus, I was in 4th grade when I got attacked the first time. Okay. Let's see. So in trying to solve the mystery of why did I end up with chronic overlapping pain conditions, we came into this new research. So the first research study talked about nerves talking to each other. We called it the pepperoni pizza algorithm, that when the bladder was irritated, the bowel became irritated. When the bowel got irritated, the bladder became irritated. And that all opened all of us up to the concept of, oh, nerves are involved. So fast forward 20 years, now for the chronic overlapping pain research, it's all about the nerves. It's all about the central nervous system. And that when we do brain scans of people with chronic overlapping pain conditions, we see constant fight or flight. You're stuck there. Your brain is habituated to fight or flight. You don't want to be there. None of us wanted to be there. You're just stuck there. It's become habitual. So how do we get ourselves out of chronic fight or flight? It's easy with really good sensory information. So I'm going to give you a technique. It works every single time. It's never not worked. And if we were on the phone, this is exactly what we would do. The language of fight or flight is sensory information. So what do you see? What do you hear? What do you smell? What do you taste? And what do you touch? We can't talk you out of fight or flight. We have to prove to your brainstem you're safe. So we're going to do that with sensory information using the I Spy technique. I Spy. Okay, so let's do it. 3 to 4 minutes. All right, shake it out a little bit. Shake it out a little bit. Let's just kind of move a little bit. Couple deep breaths in. Deep breath out. Do it with me. In. Deep breath out. You're welcome, Amanda. Okay, I want you to pick something in your room that you love to look at. I don't care what it is. Painting on the wall, a pet, look out the window. Pick something that you like to look at. So I got a beautiful painting right here by a neighbor. So focus on what you like to look at for a couple of seconds. Okay, deep breath in. Deep breath out. Okay, what do you hear besides my voice? Do you hear a TV? Is there any music playing in the background? Can you hear the wind? Can you hear a furnace? Can you hear anything right now besides my voice? Stop, close your eyes, and listen. So I hear a TV on. Deep breath in. Deep breath out. Okay. What do you smell right now? Are there any scents in the room? Any scents in the room? For me, I can smell my mango smoothie. Close your eyes and just smell. Can you smell anything? Deep breath in. Deep breath out. Okay. Do you have any tastes in your mouth? Any flavors in your mouth? Did you eat? Are you drinking something? I can taste mango smoothie with a little bit of peach yogurt. Close your eyes. Focus on taste. Are there any tastes? And if there aren't, that's fine. Okay. Deep breath in. Deep breath out. Okay, now I want you to take your hand and I want you to rub it up and down your thigh. Just do this. Right? Go slow, fast, whatever. We're engaging touch receptors in the brain. Rub back and forth. Okay, deep breath in, deep breath out. Okay, now comes the fun part. If you could look at anything that would put an immediate smile on your face, what would that be? What would you just love to look at? For me, the ocean. I would just love to be standing on a beach and watching the waves roll in. So would it be the ocean? Would it be waterfall? Would it be a pet? Would it be puppies, kittens? Pick something that you know you would just love to look at. Close your eyes and visualize that. So for me, I'm standing or sitting on the beach in Hawaii on Kahala. And just enjoy the view. Got the pelicans, seagulls flying over, children laughing over in the corner. It's a wonderful moment in time. Okay, deep breath in, deep breath out. Okay, what could you hear that would put an immediate smile on your face? What would you just love to listen to right now? Is it the ocean waves? Is it your favorite music? Is it a grandchild yelling, "Grandma, Grandma"? Pick something that you would love to listen to. So I'm going back to my old favorite, Kenny Loggins. Winnie the Pooh doesn't know what to do. Got a honey jar stuck on his nose. I love Kenny Loggins. So I want you to close your eyes, visualize what it is you would love to listen to. Deep breath in, deep breath out. Okay. What is your favorite thing to smell? Is it fresh cotton sheets? Is it the ocean? Is it baking cinnamon rolls, baking chocolate chip cookies? What would you just love to smell? You know, if you smelled it, it would bring you back to your great happy place. And for me, it's always baking cinnamon rolls. Anything hot and cinnamony is my safe place. So I want you to close your eyes and I want you to visualize that thing that you love to smell. So for me, I've got this big cinnamon roll right in front of me, steam coming off, smells fantastic. Cinnamon rolls have never tasted better than during a pandemic. Deep breath in, deep breath out. What could you taste that would put an immediate smile on your face? What is your favorite thing in the world to eat? I don't care if it's icy friendly or not. Pick something you absolutely love. And for me, easy, hot cinnamon roll every single time. So I want you to close your eyes and now imagine that you're tasting what you love. Oh my goodness. It's been a hard day. I need a reward. That cinnamon roll is a reward at the end of the day. Oh, it's just so good. Deep breath in. Deep breath out. And last but not least, what could you touch that would put an immediate smile on your face? Would it be clean cotton sheets? Would it be warm sand going through your fingers? Would it be a pet, a dog or a cat in your lap? Would it be your lover? Okay. Lovers are great to touch, right? I want you to close your eyes and I want you to imagine that you're touching whatever feels good. So I'm going to go for hot sand. Almost sand that's almost too hot, but it just feels really, really good. That's when you know you're at the beach. You know you're away from the stress of the day. It's just like you just take a deep breath in. Heaven. Deep breath in. Deep breath out. Okay, how do you feel? How do you feel? You got a smile on your face? Odds are you do. Odds are you do. So whenever you're feeling stressed, whenever you're struggling with pain, you have to remember that anxiety intensifies pain. So we've got to address the anxiety. One of the ways that you can do that is with I Spy. If you've got a child who's having trouble, like we just at my high school, we just had 2 kids were fighting and one died. It was horrible. So if you're dealing with anxiety in children, this is a great thing to do that they understand. Honey, what would you love to look at right now? What would you love to smell right now? What's your favorite smell in the world? What do you love to eat? What do you love to touch? It's a great thing to do with kids. Great thing to do with kids. But there's another piece to this puzzle. So remember, the language of fight or flight is sensory information. So we got to get right back down into good sensory information. But there's also a reality we have to deal with, and that is anxiety. We're not just anxious, we're anxious all the time. And that's normal because your life was threatened in some way. And so back in my 20s, when this was really hitting, I used to have a lot of panic attacks. I was afraid. Even though I went to work and I commuted, I had moments when I wasn't quite afraid to leave the house, but I just had a lot of fear, especially going to the doctor. I used to have panic attacks before going to the doctor. And one day I was just like, this is after getting master's degree in psychology, on my way to my PhD in psychology. I realized I didn't have the skills to stop these panic attacks. I didn't understand any of it. And so I went and signed up for a class at my local hospital that completely changed my life. And it's why I don't have panic today. Jennifer says, I feel very relaxed. Thank you so much. My blood pressure goes really when I have fear. Exactly. Okay, so I just realized when I was 35, I'm like, done. I want to fix this. So I signed up for an anxiety management class at my local hospital. And it was life-changing because I have not had a single panic attack since I took that class. Now, it was created by an orthopedic surgeon with anxiety disorder. And of course, I had anxiety just going to the class because I didn't like to go to the hospital, right? But I went. And the first thing that happened when I went to the class, literally in the first couple of minutes, is when we introduced ourselves, it was like, oh my God, we're all normal people who had something bad happen to us. The people who won the first California lottery was in my class. They developed anxiety after winning the lottery. And that took a lot of the shame away from me because I really, before that, thought that you could just look at me and see how messed up I was on the inside. And it's like, no, you're really not that messed up. You just got hurt. And the second thing he said is, here's the issue. It's just as you're sensitive to chemicals on the outside, you're also sensitive to chemicals on the inside. And right now, you are overdosing on adrenaline. You have a massive amount of adrenaline floating through your body right now. And that's what's driving the panic. And that's what's driving the tears. And that's what's driving the negative thoughts. It's that you're stuck you're just overdosing on adrenaline. Because every time you have a negative thought, you get a jolt of adrenaline. And you don't just have one negative thought a day, you have 100 negative thoughts a day. That's 100 shots of adrenaline. Of course, your body's going to be messed up with that massive amount of adrenaline. So he said, listen, I'm not here to go into your childhood and psychoanalyze you and figure out what happened. If something happened to you and you want to talk about it, I will make that happen. But we're not doing that in this class. what we're going to do in this class is get you out of fight or flight. And I'm like, okay, I'm game. I'm ready. He said the secret to reducing reducing anxiety is to reduce adrenaline. And the way you reduce adrenaline is with oxygen. So he taught us a very, very simple system. He said, whenever you have a negative thought, I want you to close your eyes and visualize a bright red stop sign. Just stop. And then you take a single deep breath, in for 3 and out for 3. And that oxygen from that negative thought has now rendered the adrenaline from the negative thought chemically neutral. It's over. It's done. Oxygen turns off adrenaline. So stop sign, deep breath. And then the third step is you have to remind yourself it's a thought. It has no power. That's just a brain kind of stuck in fight or flight. So you got to figure out something to say to yourself to remind yourself of that. So what I say to myself is, oh my God, Jill, you're not God. You can't predict the future. For all we know, tomorrow is going to be the best day in the world. There's no reason to worry about that doctor's appointment tomorrow. So stop sign, deep breath, minimize the thought. Okay. Now he said, we have one goal for this first week. Just get you out of panic. We want to get you out of adrenaline overload. So as you walk out of this room, start doing it. Stop sign, deep breath, minimize thought. Pay attention to your negative thoughts and do it. Now, I'm a chemist. I've got 2 degrees in chemistry. Chemistry appealed to me. I'm like, okay, I'll give it a shot. Had my first negative thought walking out of the room. Oh my God, this is stupid. It'll never work. But I did it. Stop sign, deep breath, minimize that thought. And that first day, I did it at least 100 times. And I was shocked because I'd gotten so used to the negative thoughts that I wasn't paying attention to them as much, but they were mean. I was mean. I was mean to me. My self-esteem was non-existent. Oh, Jill, you're an embarrassment. You're pathetic. Who would love you? Who would care for you? You're an embarrassment. You know, I was shocked at all of these negative thoughts that I was having about myself. And kind of heartbroken too. I didn't realize that I was really doing that. So anyway, the first day, at least 100 times. Second day, I did it about 50 times. The third day, I did it about 20 times. 5 days later, once. And for the first time since 4th freaking grade, I wasn't afraid. Now, I had been in adrenaline overload from 4th grade all the way to the age of 35. It was stunning. I was calm. I was relaxed. I wasn't scared. I was at rest. It was shocking to me how good I felt. I hadn't felt that way in my memory. Jennifer goes, wow. Becky says, can you repeat what you do when you have the negative thought? Stop sign, visualize a stop sign, take a nice slow deep breath in, deep breath out. And then the third step is you just have to remind yourself it's a thought and it has no power. That's just a brain that's stuck in fight or flight. So what I say is, oh my God, Jill, you're not God. You can't predict the future. For all you know, tomorrow is going to be a very blessed day. Okay? Stop sign, deep breath, minimize the thought. I have not had a panic attack since I took that class. It is what I do. And I got so good at it that I was only doing it before COVID, maybe once every 2 or 3 months. I mean, you can see my office. I'm very deliberate. I live in a very happy environment. The drapes are open. I got happy things all around me. I don't live in the dark. I live in the light. And it got so good that maybe once every 2 or 3 months, what I have to do is stop sign, deep breath, minimize the thought. But then the fires hit, and the fires are very scary. And then COVID hit. And I will tell you that I got back to doing it every day, a couple of times a day. 2 years ago, it was, but the point is I never let it get out of control. I'm very assertive here. And now I do it maybe on my own once a week now. Because we are living in uncertain and stressful times. COVID has been very scary. Fires have been very scary. This is where we are living in unprecedented time, unprecedented stressful times. But the point is that we're never, ever, ever going to let it get out of control again. The enemy is adrenaline. So when I have a negative thought, stop sign, deep breath, minimize the thought. Sometimes I let the first one slide, but if I have 2 in a row, bam, I lock down hard. If I have 3 in a row, I'm very aggressive. I'm very assertive. Marianne says, I can't imagine having that kind of anxiety, constant anxiety. And my story is mild compared to some of the stories you guys have shared with me. I mean, I've worked with IC patients who've been terribly, terribly, viciously, physically abused. And the point here is what I learned in that class. We are normal people who just had something happen to us. And it's really not about us at all. It was never my fault. It's not your fault. You got hurt. I got hurt. It's okay. And we now know exactly what to do to calm things down. I don't live with IBS anymore. I don't live with IC anymore. I don't live with 95% of the pain and the dysfunction that I had anymore now that I've calmed my central nervous system down. Yes, I have a bad SI joint that tweaks my pelvic floor. That is true. And my TMJ gets wonky, definitely. But all of that residual nerve pain for the most part is gone. And you know, when I had my hysterectomy and they did the hydrodistension to look at my bladder, and I had my post-op appointment with my doc, he showed me my bladder. He goes, Jill, you have a beautiful bladder. There is nothing physically wrong with your bladder. This proves beyond a shadow of a doubt that you are nerve and muscle driven. And when you are sensitive, we are sensitive. I'm a redhead. Hello, we're sensitive. I have a sensitive stomach. So you're not going to see me eating hot, spicy things every day. I'm going to respect that sensitivity. I have a sensitive bladder, but not so much anymore. I mean, I can eat anything. I've been eating oranges. I've been eating a lot of mandarin oranges for the last month. No flares. Because everything's calmed down. So I double dog dare you to try it. Stop sign, deep breath, minimize the thought. So for those of you who live with anxiety every day, you are not alone. I am your complete sister. But there is hope. We have to learn that skill. We weren't born with these skills. We have to learn these skills. And learning to aggressively combat those negative thoughts is really important. By substituting in positive thoughts, Norman Vincent Peale, all that sort of stuff. I can do all things through Christ who strengthens me, or whatever your affirmation is. It takes work, but it's doable. And so I double dog dare you to try it. I Spy and my favorite, stop sign, deep breath, minimize the thought. Life-changing. And I will tell you, you know, it's so interesting working with patients on the phone because so many of you you're like my identical twin. Something, you know, childhood trauma, chronic overlapping pain conditions over time, stuck thinking it's a bladder disease. It's not. You have a healthy bladder. It's a neurological issue that we got to calm down. So anyway, well, listen, let me see if I can get Zoom started. So hold on a sec. No, I have to start Zoom on that computer. I don't think it's going to let me start it on this computer. So hold on a sec. Let me see if I can start it. And it says my keyboard's going to run out of battery here. Let me plug this in. All right. Zoom, Zoom, Zoom. Where are you, Zoom? There you are. Okay, it's really weird. Hold on. You got to give me a minute to try to. Normally, I used to go into our Zoom through our website. Let me try that and see if that's going to work first. Stream support group meetings. Zoom. Yes, I want this page to open it. PK says, took 6 Advil at one time because I didn't remember. I just took 3, so I think the Advil caused inflammation in my colon, and it can, honey. It can. Advil is notorious for causing gut issues. No doubt about that. Okay, so hold on. Let me see if it's going to let me launch a meeting. Let me see if it'll reset my, okay. I need to try to get Zoom on my streaming computer, so hold on a sec. Okay, so I just got an email. Click here to change your password. Okay, hold on. Hold on. Okay, this is promising. Are you going to let me in? Okay, I'm successfully logged in. Now let me host a meeting with video on. Allow. Oh, yeah, baby. Oh, hey, look at that. Okay, so let me get a invite link. Okay, so for Facebook, I'm going to give you, does hydrodistension help lessen IC pain, improve capacity? Only on the short term. It will reduce pain because it breaks nerves, but the nerves always grow back. Okay, so Facebook, you guys have the link. Not everybody has inflammation of the bladder wall, Linda. The vast majority of IC patients do not have inflammation of the bladder wall on biopsy. Okay, so hold on a sec. Now I have to email the link to my other computer. Oh, no, I don't. No, yes, I do. Hold on. Okay, so hold on. All right, so YouTube, you're going to get your link. Here we go. PK said it all started when I took Cipro and diflucan. All right. So for those of you on YouTube, there you go. There's your link to Zoom. So if you want to come to Zoom, now realize when you come to Zoom, we're still, I'm still broadcasting live on YouTube and on Facebook. So let's see, we've got Jeannie in. Let's see. Let's give it a couple minutes. I've got two of you. I mean, I've got one of you. All right, Becky. I'm letting Becky in. Alina, we're letting Alina in. Hello, hello. Hi, you guys. Oh, look at that cute baby. Oh, my goodness. All right, let me check back in with Facebook here for a moment. Whoops. Nope. Where did my Facebook go? Okay. What is the YouTube link? I'll give it to you right here. Or the Zoom link is right here. The anxiety exercises in a post you can share. Michelle, they're in our magazine, and you're the second person to ask me that. I will, you know what I want to do is I want to clip the section of the video out and make it another video. I've just been so busy, I haven't had a chance to do that. But we've done that regularly for the past couple of years in these live meetings. And I always do it on the phone with people too. All right, Amy's coming in. Hello, Amy. Okay, so for those of you, so YouTube cannot see your faces. Facebook cannot see your face, but they are going to hear you. So are you okay with that? For people in Zoom, just do this or do this. You're okay with that? Mm-hmm. Okay, so what I'm going to do here is, now you guys, I'm going to try to do you in the order that you came in. So for those of you that I'm not talking to, I'm going to, if you can mute yourself, and let's go and let's make sure, is there anybody else who's having trouble getting in? Where is the magazine on your website? Under, here, hold on, I can get it for you. Oh God. I'm always scared to close windows when I'm doing a live stream because I never know if I'm going to accidentally turn something off. So if you go to the IC Network website, it's under news and blogs. It's the first link. And so just go to icnetwork.org, go to news and blogs. It's the first link. It's called the IC Optimist. Okay. So let us hear from Jeannie.
Hi.
Hey, hon, how are you today? How is life?
I'm in an awful place right now.
Okay. What's going on?
Just to give you a little history, back in August, I had 300 lesions cauterized.
Okay.
Then in December, I had a hydrodistension and a bladder wash. That got me about 50% better, but then they injected me with Flexeril.
Okay.
And that sent me back to day one.
Huh? Okay, wait. I just have to ask you questions in the middle of this. So bear with me here, because it just helps me. So you had 300 lesions removed. Then in December, they did a hydrodistension and a bladder wash. Were the Hunner's lesions healed, or were they still open in December?
No, they were healed.
They were healed. And then they did a bladder wash. What, because we don't do bladder washes anymore. that implies that they're cleaning something. So what did they put in your bladder?
I don't know what they did for the wash, but they were looking for any cancer in the lining of the bladder. And
Interesting.
there wasn't any, so that was good.
Okay. And then they gave you an injection of Flexeril?
I'm not sure if it was Flexeril. What's that Botox? It wasn't Botox. It was another one that they do like Botox. And
Okay.
after the bladder wash, I got about 50% better.
Okay.
Then they did the injection and it put me back to square one. And then just 4 weeks ago, I had the mesh sling removal because it was eroding. So
Yeah.
I'm in a lot of pain
Oh,
from
yeah.
that. Still in a lot of pain when I pee, burning, stinging. I don't know. I'm kind of in the middle of it now. Like they messed up my pain meds because there was a shortage at the pharmacy.
Okay.
And I'm telling you what a world of hurt that was.
Oh, yeah. Yeah. Well, and mesh surgery, I mean, so here, number one, you had Hunner's lesions, which are the most painful form of IC. The good news is that it healed, but then they gave you an injection of something like Botox. When you had that injection, was it harder for you to urinate?
No, it just sent my into a flare that never's gone away. You're welcome.
Can you, is this a painful flare or a frequency urgency flare?
Both.
Where is,
It's
okay.
constant. I wouldn't even call it a flare anymore. It's how I
Okay,
live.
where is the pain located? Is it on the outside of your body or inside of your body?
My vagina, my urethra, sometimes in my buttocks.
Okay.
There's a stinging and burning all around my vagina when I pee in my urethra.
So mesh removal. So for those of you listening or watching, Jeannie apparently had some sort of prolapse, and they went in to repair it by using some polypropylene mesh, which acts to kind of stabilize tissue and hold tissue in place. Unfortunately, now we know that mesh actually does not belong in the human body, and it erodes through tissue. So mesh can move. And so it's very common for women who had mesh surgeries to, when they had sex, their husbands would feel plastic in their vagina that was rough, that would hurt them during sex. So mesh is known for going through the vaginal wall, into the bladder, into the urethra. So where had your mesh eroded to?
He just said I forget what he said. The doctor just said just down in your pelvic floor, down the whole pelvic area. He said the whole pelvic area.
Okay. Okay. Mesh surgeries are brutal. Mesh removal surgeries are brutal. You are in the middle of your recovery from the mesh surgery. So it doesn't surprise me that you're having a lot of discomfort. I mean, It's been how long? 3 weeks?
4 weeks.
Girl, I'm impressed that are you sitting or laying in a bed? How is sitting for you?
That can be very difficult. I'm laying in bed right now. Walking is excruciating without pain meds. I can walk with pain meds, but I can walk ever so slowly when I don't have any pain medication.
What did the surgeon say about the removal? Was the removal very difficult? Was removal
easy?
Okay.
No, it was very complicated. You had to pick at it because it was in there so well.
Right.
So complicated, and I was a bleeder. I really bled a lot. They had to pack me. 3 or 4 days later, unpack me and pack me again. So it was pretty brutal.
So do you feel like you have good pain care now?
Yes, it's just that the pharmacy was out of it, and I had to wait a couple of days.
Oh, that's not good.
Okay. No.
Are you finding, where's your incision?
In my vagina.
Okay. Okay. Are you allowed to use heat or ice? What do they want you to do?
Nothing in the vagina, no baths, nothing, just showers.
Okay. Okay.
And she's going to see me in another 3.5 weeks and reevaluate that.
Yeah, because you're not going to be able to have physical therapy for several months, probably.
Right. She said the next step would be physical therapy.
Yeah, but you're looking probably at least I didn't have physical therapy for 10 months after my hysterectomy, and I had a vaginal incision too. Well, you're honey, I giving you a hug. Number one, you're not alone. Many women have gone through this. You should Google mesh class action lawsuits, because there are a lot of lawsuits going on. I mean, that's a whole nother story. And it's either 60 Minutes or Frontline did a fabulous documentary on mesh. Like literally, the American company that made the mesh, that gave it to the pharmaceutical company, stopped giving it to them because they said polypropylene should never be in the human body. So the company went to China instead, and they bought a lot of stuff from China. But they actually had to change the labels and lie on the labeling to even get it imported back to the U.S. So there's a great documentary out there. You got to look at it because you may be. I think it's very important that you understand that you are a victim and of the mesh industry. And if there's compensation for you, if I were you, I would be seeking that and learning a lot more about that. In the meantime, girl, you're just in your post-op recovery. You got to do everything you can to protect your bladder. Not the time to cheat on your diet at all. I would be doing a chamomile tea every day or peppermint herbal tea. I would. The only other thing that I can think of that might be interesting, but remember, I'm not a doctor. I can't give you medical advice. Never. My job is to get you back to your doctor, not to interfere in that relationship. Um, Things that calm nerves down, because it's your nerves that are really traumatized right now, would be reasonable. And so you might want to look at palmitoyl ethanolamide, PEA.
And
But
he had me taking he had me taking L-arginine and a cranberry that doesn't have the bad kind of cranberry in it.
okay, for what? Do you have a history of infection?
No, for the bladder, to calm the bladder down.
Well, cranberry's not going to calm the bladder. It's just going to, the proanthocyanidins from cranberry are going to make it more difficult to get infected, because if you were catheterized, then the odds of you getting infection are pretty substantial. But it's not going to calm the bladder down that I'm aware of at all.
So PEA, try PEA.
Well, PEA, I mean, I would Google PEA, surgical pain relief, acute pain relief. They've done a lot of research with it in Europe, and I have seen surgical pain research studies which shown that it's been helpful. So don't believe me. I want you to do your own due diligence. And let me put in the chat here. I'm going to spell it out for you. Palmitoyl. Let me see. Hold on. So go to pubmed.gov. Oops, hold on. Can I type? And search for PEA acute pain or surgical pain. And you look at that research and you see what if that's something you want to talk to your doctor about, okay?
Okay. But so all this burning and stinging and pulling, and this is all normal after surgery?
Especially the surgery you had. I mean,
okay.
Are you getting up at night? Do you have a lot of frequency?
Yes, I get up about 15 times a night.
Is that gotten worse or better since you had the surgery?
I would say a little worse. And they just put me on Detrol to see if that helps. It's an old medication because Mirabetrix and all the other ones didn't work.
Is there, when you had the mesh surgery, did they do a hydrodistension afterwards just to make sure that they didn't accidentally put a suture through your bladder or anything like that?
No, they just did a looky-loo in the bladder.
Okay, and they didn't see any, so it didn't look like your bladder was compromised in the surgery. Did they take any mesh off of your bladder?
They took it off. They took it out. I don't know exactly where from. I should find that out.
Yeah. Are you taking any vitamins or any other supplements?
Just vitamin D and calcium.
Good. Okay. Good. Are you drinking water out of a Brita water filter?
No.
Okay. Are you and you're not taking any other supplements? Nothing else?
just the L-arginine, like I said, and magnesiums to help regulate me.
Okay. Okay. Well, hon, when I go back to week 3 after my hysterectomy, I was barely functional.
Oh, okay.
And I walked around with my hands over my belly for about 3 months. I think you're probably going to be in a wait and see. Of course, if you spike a fever, if you get scared, if your pain goes over the top, if you pee blood, anything at all like that, that's an immediate call to your doctor or a trip to the emergency room. But I'm not surprised that you're struggling.
Yeah.
Okay.
That's reassuring.
But just remember, the human body's wired to heal. It's healing right now. It's trying to repair whatever damage is done. It just takes time, hun. It just takes time, a lot of time. Okay.
Okay.
Okay, hon. Big giant hug to you. And the good news here is you're over the worst. You're over the worst. You had the surgery. Praise God.
Yeah.
Hallelujah. You've had the surgery. Now we're just in a healing process. Right?
Yep.
Okay, hon. Nice talking with you. Big giant hug to you.
Okay. Bye-bye.
Okay. Now, let's see. So okay, I see. I'm not sure who came in next. Oh, was it, okay. You guys don't take it personally if I call on you, if somebody else came in first. So let's go to Alina. Okay. Alina, can you hear me?
Yes, hold on.
All right, honey. How can I help you? What's going on with you today?
Can you hear me?
I can.
Good. So I'm just wondering, so probably about 5 years ago is when I started feeling like my IC symptoms.
Mm-hmm.
Well, and I don't was IC.
Okay.
But yeah, so that was like 5 years ago. I did the bladder installations for like a couple months, and then pretty much just kind of went, doing marshmallow root, just things like that. Anyways, totally fine. Good, no issues. 5 years, great. I was like, okay, that's over and done with. And then I would say this December, which I think was a lot due to stress.
Yeah.
Really, I'm like, that's where I feel like everything just started.
Okay.
And then, sure enough, in December is when I started feeling it, and I'm getting better. But yeah, I'm kind of confused. Like I was like, I've been good for 5 years. I mean, I could drink anything, nothing, no problem. It was the past, and then all of a sudden it just came up. But like I said, I been going through a lot of stress since December.
Okay.
And
okay. So how old are you?
I'm 40.
Okay, so your symptoms started when you were 35. Was there any event that you associate with the onset of your symptoms, like having a baby, car accident, a fall, anything at all like that?
So I just have one son.
Okay.
My team had a C-section. I did have, and like I said, I'm still trying to figure out something. I did have an IUD in for 10, 15 years.
Okay.
And I feel like after I removed the IUD, which was really painful because it had just really
awful.
I feel like kind of slowly that's where symptoms were going. Plus, at that time, I was going through another stressful issue.
Okay.
So yeah.
And prior to this, when you were a kid, did you know all the bathrooms in town? Can you remember having any bladder issues when you were a kid?
No.
Okay.
I think my first UTI was after my pregnancy, and that was like once.
Okay.
Every year.
And how old were you when you had your baby?
20.
Okay, so that was a long time before you had your symptoms.
Mm-hmm.
Okay, and I'm just letting Loretta into the room too. All right,
Okay.
Loretta, hold tight. So were you an athlete when you were a kid? Did you do any sports? Were you a bike rider, horseback rider, gymnast, dancer?
I did dance, but nothing really.
What kind of dance did you do?
Just like normal, like regular. Yeah, I mean, I love to dance, so I
Okay.
wasn't like I'm.
Did you ever do ballet?
No.
Okay,
Mm-mm.
good. Tell us about your symptoms then. What are your symptoms now?
I just kind of more tightness. That's really what I feel like most of it. I don't get up at night. I mean, like I hear about different icy symptoms, and I'm like, I must have like a very, very mild case.
Yeah.
Like I said, I don't get up at night. I
Okay,
do fine.
are you food sensitive?
No, nuh-uh.
Okay.
Right now I'm holding down, but I feel like it's just tight to where like, yeah, maybe I need to go to the bathroom. Right now, when I do go to the bathroom,
Yeah.
like, so I'm at work right now. I got up at 6 or 5:30, went to the bathroom. I didn't go to the bathroom until probably 2 o'clock.
Okay. So
Went to the bathroom. After that, once I go, then that tightness kind of comes in.
okay. Are you straining to go to the bathroom? Are you pushing?
No,
When you go to pee, can you start your stream right away, or are you hesitating 5, 10, 15, 20 seconds?
I'll just go.
Are you peeing like a horse, or are you stopping and starting?
No, it's flowing. Sometimes it'll go really good, and then there's some times where it's going, but it's just slow. But I'm not like pushing down it. It's just going just fine.
Okay.
So,
Do you ever have sciatica? Do you ever have pain that shoots down your leg?
no.
Okay. Do you ever have any other pain anywhere in your body?
Sorry,
Do you have any other pain besides your body? I mean, but besides your pelvis, do you ever have headaches, migraines, anything at all like that? Do you have very sensitive skin? Do you have a wicked sense of smell? Can you smell things that other people can't smell, and do smells drive you crazy?
No.
Okay. Have you had a pelvic floor assessment?
I haven't.
Okay, that's your next step, because the first thing you said was tight. You feel tight.
Yeah.
Do your symptoms change with body position? Like when you sit down, does it get worse? When you stand up, does it get better?
No. Like right now it feels a little tight, but I think because I need to go to the bathroom, so I'll go to the bathroom.
It's really rare that somebody would describe a bladder symptom as tight.
Okay.
Do you feel a pulling sensation or a pushing sensation?
Not a pushing, not a pulling, just tight, like
Okay.
that.
Well, number one, you're not food sensitive. Number two, you can hold your urine forever. Your bladder wall sounds perfectly healthy. I mean, you could have. Are you on birth control now?
No.
Okay, so ask your mom when she started going to perimenopause, because there's a chance, like the girl I was working with earlier, who went into menopause in her late 30s. So it would be interesting to see if that could be playing a role. But I think your next step is to get a proper pelvic floor assessment.
Okay.
Because we don't describe, you're not having bladder symptoms. You're really not.
Yeah. The only thing, like I said, and I've in the past I started having, well, 5 years ago when I started, I remember I just always wanted to go to the bathroom, and then I went for UTI and I didn't have anything. And then I would literally, I'd just be standing in the living room and just try and push out urine just to see if maybe I needed to go. That was back then. I haven't had that symptom.
But think about the language you just used. Trying to push out urine. You were straining. You were straining. And so this could be something as simple as, I mean, can you remember falling 5 years ago? Did you ever fall on ice? Were you riding a bicycle? Anything at all like that?
No, I mean, like years ago, with snowboarding, I fell, and I'm pretty sure I hurt my tailbone, but that's the only
major. That's all you got to say, that tailbone injury. Tailbone injuries are absolutely very strongly correlated with tight pelvic floor muscles and pelvic floor dysfunction. And the reason why, if you think about this, is let's look here for a moment at the tailbone. And I want you to see everything that's connected to it. The tailbone is really the center point of your pelvic floor. So we got muscles that go this way, and we got muscles that go this way. And if your tailbone is bent out of shape, and you also know it curls underneath a little bit. It doesn't curl out. It doesn't stick out. It curls underneath. But if you suffer a big tailbone injury, and if that tailbone starts to stick out a little bit, that could explain everything. So if I were you, my next step would be to get a proper pelvic floor assessment, and you have to tell them about the tailbone injury.
Okay.
And you know who was the one who started talking about this? Because we never talked about tailbone injuries until he started talking about tailbone injuries.
Okay.
And there are just a massive number of tailbone injuries in patients with pelvic floor. And my symptoms began in 7th grade when I broke my tailbone.
Okay.
So
just real quick, this is what's kind of caused me pause a little bit on what I'm eating, and I'm just been kind of just being careful, just kind of get my body rechecked.
Yeah.
So Super Bowl, like I said, I had been okay. Super Bowl, I had a few vodka shots, and I shouldn't have it. The couple of days after, boom, this is when I was like, wow, this is what I think a flare up means, and it's not fun. I've never really had anything like that. And after that, like I said, I've been recuperating from that. And
but if your muscles have been tight for a long time, you're in ischemia, oxygen deprivation. Your muscles are so tight, they're squeezing blood vessels. That's called ischemia. So if your bladder is supposed to get 24 units of blood a day and it's only getting 10, your bladder wall's compromised.
Okay.
But for that bladder wall patient, that pelvic floor patient, you could do bladder therapies to the end of time and you'll never get better, because bladder therapies will not fix the underlying problem, which is ischemia, which is poor blood supply from tight muscles.
Okay.
And if you look at our new guidelines, they want a pelvic floor assessment done at the very first appointment.
Okay.
And if they find tight pelvic floor muscles, it's an immediate referral to pelvic floor physical therapy. So that's the missing piece.
Next Monday. So
good. Okay. Well, I hope you let us know what they find, and I'm going to predict that you've got tight piriformis muscles from your tailbone.
Okay, which I'm okay with that.
Hey,
I'm like, I don't want the other stuff. So
well, that's why it's so important that you stop thinking about this as a disease.
Okay.
There's no disease process happening in your bladder. You're not peeing blood. You have a normal bladder. You have normal bladder behavior.
Okay.
What you don't have, are bladder wall symptoms per se, other than the vodka, but that was once. But your language is important. You said tight. So we need to follow that first. Okay?
Okay.
All right, hon. Nice talking with you.
Yeah.
You're very welcome. Okay. I don't know if Becky is still there or not. Becky, are you there?
I'm here. I was putting the baby down.
Oh, you have a gorgeous baby. How old is he?
Thank you. He's almost 8 months.
See, you're living proof that I see patients have babies all the time, and you're great moms.
Yeah, I had IC for 10 years before I had the baby. So
yeah. So just fair warning, Amy, I'm going to come to you next, then I'm going to Kelly. Okay.
I'll be pretty fast. I'm doing okay, and I pretty much know what to do. I'm looking for some motivation. I think things changed a little bit after I had the baby. I was hoping that I was going to be one of these people who, and I'm 40 years old. This is my first baby.
You are not 40. No, you are not 40 years old.
I'm almost 40.
No way.
I'm 39.
Well, you'd never know it. You look like you're 24.
Thank you. I get that sometimes, but I feel like I used to look young, and I don't feel like I look young anymore.
Well, you look young.
So
what are you struggling with? Are you flaring? What are you struggling with right now?
Yeah. So I thought I was going to be one of these folks who feels better when they get pregnant, and that wasn't the case. But I do feel like since I've had the baby, In a way, it's better. But I do have a prolapse, which I haven't like really been treated or diagnosed, but I was a hypertonic pelvic floor before.
Okay.
And I think I still have some of that. And I'm also dealing with prolapse, you know? So it's like, I still have this like pain, like external pelvic floor pain. I get this thing where like my clitoris doesn't function because of the, so I have to like go into physical therapy and get, some help because I know what to do myself, but it's like it doesn't work as well when I do it. So I usually like go in, every year or so for some sessions. But it's just hard now because I have the baby and I work and I don't know, like you talk about pelvic congestion syndrome, like I think I'm probably have that as well based on how you describe it. And my food sensitivity has kind of gone down, but recently I've been expanding my diet and I'm not having the pain as much, but it does give me frequency. And then I have a lot of leakage too, because it's like I don't know exactly what's going on with my pelvic floor. So like I know I need to get into physical therapy, but I don't know. I just need the motivation because it's like I have so much going on in my life.
Well,
I
what's really sad about American healthcare is virtually everywhere else, a woman who's had a baby is sent to physical therapy. But with our health insurance system, they don't want to pay for it. So women who have had deliveries, especially difficult deliveries, you're still not sent to physical therapy, and still you ask for it. You just have to understand that childbirth is very traumatic. I can remember in high school, my teacher Jim Jordan said, and it always stayed with me. I was a senior in high school. He said, "The biggest gift that a woman can give a man is to risk her life to bear his child." Because childbirth is traumatic. Childbirth can be life-changing for some women physically if they suffer a severe tear or anything at all like that. So,
Right.
so girl, come on now, get yourself into physical therapy. It's fun. I mean, it's fun. That's okay. That sounds weird. Okay, let me say it a different way.
Thank you.
I have a therapist I really like.
Yeah.
And she does private practice on the weekend.
Okay.
So I did that like one time before I had the baby, and I was there one time after. But I don't know, things hadn't gotten as bad at that point, and she was like, "Well, you know what to do, and you're doing okay." But
yeah,
it's like not,
okay. But concept number one is you think you have a prolapse. Why do you think you have a prolapse? What's your symptom? Are you feeling a bulge?
Yeah, I can feel it. To me, it feels like I never got to go to my postpartum like 6-week appointment. I ended up having that virtually because I was in a car accident.
Okay.
Which I didn't get hurt in an accident, but I couldn't get there. And it feels to me like my front vaginal wall is like laying across the vaginal opening.
Oh, interesting.
And I had a good birth. Like I did it unmedicated, and it was like fairly quick. But then that sort of developed afterwards.
Okay, but literally, you have not had a vaginal exam to validate the prolapse yet?
No, and so I'm going to. It'll be my second time going to the Urogyn coming up like next month because it takes forever to get in too.
Yeah, it does.
And and last time she didn't like examine me. We just kind of talked and
okay, it's time for a proper examination, don't you think?
Yeah, totally. Especially I'm having some pain too. Like in the perineum area, and I didn't get any stitches there, but I think like maybe I should have, maybe I did need them, So, yeah.
Well,
so I guess I just wait and see what she says, and then she'll give me a referral to physical therapy because, like, I don't know, I don't want to do it on the weekends. Like, it's more expensive, but also it's just like, it takes up my weekend time, and I feel like that's like my time to be with my family.
Yeah, I can understand that. I don't know. I mean, I think that I don't like guessing. I like facts. And one of the things that, because I'm 62 now, right? Like, so when I was back in my 30s, I waited and waited and waited and again, I've shared, I used to have panic attack going to the doctors anyway. And there was just kind of there were a couple of moments for me that changed that. Number one, the vast majority of time, the things I was worried about and getting upset about were never real. I'd walk into the doctor terrified I had cancer, and he goes, "No, Jill, it's a freckle. Stop it. You're fine, right?" And I caught myself worrying for long, long periods of time about, is it this, is it that? And then finally, living in fear and worry for a long time, getting myself into the doctor and discovering after the fact, God, I just wasted 3 months worrying about something that I didn't need to worry about. And so I changed it and I went, okay, if I have anything that is upsetting me, I go immediately. I don't wait anymore. I just go. I just want somebody to look at it. And so I think that you have a good educated guess. It's your body. You know what feels normal and what doesn't feel normal. I would want somebody to look at what's happening in your vaginal entrance, because what's in front of your vagina but your bladder, right?
Yeah, I'm having some incontinence.
Yeah.
Mostly urinary, but also a couple times fecal incontinence too.
Yeah,
So
yeah. So
um,
it's time to get your tush into the doctor, and let's just be real honest about it. Tell her you're having moments of incontinence. This is very common after childbirth. Tell them you're having moments of fecal incontinence every now and then, and that you're feeling this thing. And it sounds like you have a birth injury. It does. It sounds like you have a birth injury. They're common, and so let's go in, figure it out, and get an expert's opinion to see what we can do. It might mean that you might need to use a pessary.
yeah.
Do you know what a pessary is?
Mm-hmm. Yeah.
I mean, that might, I mean, the thing we all have to understand as women is our muscles change with time. And they change with aging. And generally, they get weaker as we get older. Anyway, the loss of estrogen causes muscles to get weaker. And so once you're of a certain age, it's more common to have a little bit more incontinence. When I walk, there are moments when I feel like I could be incontinent. Hasn't quite happened yet, but I have lost it a couple of times, usually when I get surprised or if I fall down. So, but you had the ultimate trauma to your pelvic floor. You had a big baby, right? And so I think you're dealing probably with a little bit of a birth injury, birth trauma. So you and millions of other women. And so let's get an expert to look at it and see if they can understand this a little bit more and see what your treatment options are. But that's not IC, hun. That's not IC.
Yeah.
I mean,
Yeah, because oddly, it seems like I've been doing better with the diet. Like, I've been branching out a little bit, and it's been okay.
Yeah.
But
I'm not surprised. I'm not surprised you're better
I
because
think with my bladder wall, like I think I took care of that. I was a big diet soda drinker, and it's been 10 years now since I haven't been doing that anymore.
Good.
And I've been on the estrogen cream since I was 34.
Why? Why?
Because taking birth control apparently can cause. Yeah. So I was diagnosed with atrophy, but I had it longer than that. But the doctor I had been going to, he kept saying, "Oh, this is like you're getting older. This is within the range of normal." At the time, I was like, "I'm 32. I'm not older. Like this isn't normal." And I didn't know what was going on. And then when I went to this new doctor, she said, "Oh, you have vaginal atrophy," and I was like, "That sounds terrible,"
No.
But yeah, she thinks it's birth control that did it.
Yeah.
I was on that for a long time.
That's what happens. I mean, I welcome to the sisterhood. We're all going to deal with it. You just dealt with it at a very young age, and I've shared the story of the 18-year-old who we have a case study published in a paper of an 18-year-old who developed severe urinary symptoms. And it came right back down to, and she was diagnosed with IC, diagnosed with chronic UTI, diagnosed with chronic yeast, all those things.
Mm-hmm. I thought it was yeast. Mm-hmm. I thought it was yeast.
And in the end for her, it was that she just started birth control and it put her into an early menopause. When she stopped the birth control, it took 6 weeks, all of her symptoms went away.
Yeah, the doctor called it pseudo-menopause, and she said, like, stopping it might not change it. But I did stop it when I was 35, and I didn't have periods, I think, from when I was 22, and then they started to come back when I was 36. So it wasn't until I was 38 that I got pregnant. Like, I thought I needed the birth control to, like, regulate my periods, but
yeah, we won't talk about big pharma and their messages. So anyway, so your next step, in my opinion, get in and have a proper assessment, and let's see what's going on structurally in there. Okay. No shame, no blame. You didn't do anything wrong, girl. You had a baby. You have a beautiful baby, right?
Yes. Yeah, I'm very fortunate. He's a great baby too. He's really, really calm and easy baby. But yeah. So when I get to the doctor in April, I'm gonna say, like, I need to be examined. Like, it's not gonna be just like talking about how my medications are going.
I mean, I think that you could call and make an earlier appointment, and I think you need to you need to describe the prolapse and see if you can get in a little bit earlier. April, you waiting another 5 weeks might be pushing it a little bit. It would be nice to get somebody to look at it a little bit more quickly. Yeah. I don't know. Be the squeaky wheel. Be the squeaky wheel and see, especially if you're feeling anything falling out of you, you should get right into the doctor. Okay. And I hope you let us know what they find, because this is all treatable. Okay.
Okay. Yeah. I join when I can. I'm on here a lot.
Good. Well, if you need a pep talk before your appointment, give me a phone call. I give really good pep talks. Okay.
Thank you, Jill.
Oh, you're very, very welcome. And kiss that little baby. He's adorable.
Oh, thank you.
Okay, Amy.
Bye-bye.
Gotta unmute myself here.
How are you today?
I'm doing okay. I've had a rough couple weeks.
Okay, what's going on?
I was the one that was in your chat before that had so I have been feeling better for 6 months. I had what I thought was pelvic floor related. And then 2 weeks ago, out of the clear blue, I started having these burning, scabbing symptoms again, and they come and they go. I never notice if they're like, it's not, I don't think it's positional. I don't think it has to do with me sitting or anything. I do feel like it's on the left side more, but then like sometimes I freak myself out. I catastrophize everything.
Yeah.
Like when you said that you like will waste 3 months of your life thinking that it's something, that's totally me.
Yeah, exactly.
And so I just keep thinking like maybe it's my bladder, but I've had a cystoscopy and they're like, your bladder looks fine. There's nothing wrong.
Yeah.
But sometimes it feels like it's hard. The symptoms are also different. Like sometimes it feels like I can't hold my pee and like I have to go. But I know that can be a bunch of different things.
Well, the problem with the pelvis is it's a very small confined area with a lot of stuff happening in there. So, we've got skeletal muscle that help you open and close your legs and walk. We've got big giant nerves. We've got giant blood vessels. And of course, we've got our urinary tract, our reproductive tract, and our GI tract. And the problem is nothing operates in isolation. Everything influences everything else. And so it's really easy to go, but it's my bladder, but it could easily not be your bladder. And the connection between all of these really is nerves, because the nerves are shared. So the nerves for your bladder, the nerves for your vulva, the nerves for your clitoris, all those all merge at the same part of the spinal cord, and they actually become the same nerve. And so there's a lot of what we call neuro crosstalk going on. So if it were bladder pain, you would have centralized pain. It would be, and of course I'm wearing the wrong thing right now. So here's my belly button, straight down. Your bladder is directly below your belly button, right above your pubic bone. So that's exactly where your bladder is. But you're describing pain over here.
Well, sometimes I do feel it centrally.
Yeah, yeah, but
I feel it down left into my leg too, like into my groin area.
Okay, so you are describing a nerve. You're describing a nerve that's either maybe you have a compressed disc in your back, or you've got tight muscles on your left side. That's really what you're describing more than anything else. Have you been, say, to a physical therapist? Have you had a pelvic floor assessment?
Yeah, so I have been dealing with this, like it came out of the clear blue a year and a half ago.
Okay.
And so that's when I had like the cystoscopy and the ultrasound. Like I had all the tests done, CAT scans. I haven't had an MRI.
Okay.
But the doctors are always like, "You're fine. There's nothing wrong with you. Everything's checked out." And so then I went to PT, and PT is what I thought made me feel better for 6 months. And so now I've been going again, and I've gone 4 times, but I haven't really noticed a difference yet.
Yeah, but when you went to physical therapy the first time, were your muscles tight? How did she describe your symptoms?
Well, it's interesting because I'm now on my 5th physical therapist. And they've all told me different things, but this one that I'm seeing now, she's been practicing pelvic floor PT for like 25 years.
Okay.
And so she's like, "Amy, I know what I feel, and I feel like you are tight."
Okay. And are you tighter on the left side than the right side?
Now, it's interesting because she says that she feels tightness on the right side.
I've had that same experience.
Okay.
So, often when I was doing physical, and I do it at home now. I have my wand, and I can feel my sensations on the left side, but when I get internally, it's the right side that's the most painful. Right. And so there's just lots of bounce back ripple effects between nerves, for lack of a better term. I think you need to follow that line of thought. Did you tell her about the pain that goes down your inner left thigh?
Yes, and she also dry needles. So she's been dry needling my adductor. She's been dry needling. I have a bad SI joint that hurts on my left side.
Are you do you wear an SI belt?
I do not.
You don't? Here, I'll show you mine. Oh, I have. Listen, mine was really bad this week. That's one reason why I'm wearing a onesie. So an SI belt, you put right over the SI joint.
Okay.
And so now it's completely stabilized.
Right.
So I can walk miles in this. If I only have to use this when my joint gets tweaked, which it was tweaked this week.
Yeah.
And I woke up yesterday morning with my muscle fluttering like this. Like I feel up my whole body. The muscle, the piriformis muscle, was just going crazy over this SI joint. Do you use muscle relaxants? Have you ever tried a vaginal Valium suppository or Flexeril or anything like that?
I do have some of those. I also have gabapentin here. And I feel like it takes the edge off, but it doesn't like get rid of it completely.
Do you know what's wrong? Do you know what's wrong with your SI joint? Is it just flexible? What have they said about it?
That I don't know.
Have you been to a physiatrist yet?
No.
Oh, you should. I mean, ultimately, in the end, what puts long-term chronic pressure on muscles but bones? And you have a bad joint like I have a bad joint, and it's very important that you open up that discussion with a physiatrist or an orthopedic surgeon so that you can look at body mechanics, but how you walk, because a lot of things influence the SI joint. And if you played racket sports like I did, this is the racket sport injury. Yeah. So, but golfing could potentially do this.
I golf.
Oh, there you go. Well, I mean, think about your golf swing. Oh, look at that. I do this every now and then. I just hit my chair. I would want to go to a really good sports physical therapist who works with athletes to really work on what can you do around the SI joint area to try to make sure the muscles are healthy there. I mean, so it's not just going to be internal work; it's going to be probably external work also. Yeah, but that's your operating theater, for lack of a better term. You've got to really work on that joint and everything that's affecting that joint. One of the things that they can do, and I was going to do it right before COVID, is called prolotherapy. Prolotherapy is where they inject a little salt solution into a ligament that helps stabilize the joint.
Oh.
And I have scoliosis. Do you have scoliosis?
I don't.
Okay. I have a little S curve in my back. Anyway, sometimes that slight rotation can also trigger a slight rotation in the hip, which then tweaks the anyway. So prolotherapy might be an interesting option for you. I will tell you that when I talk to I'm stuck in Kaiser. Kaiser's not very good at stuff like this. And my physiatrist was like, well, I've only done it a couple of times. And I'm like, great. So I know that for me over the long term, working on my SI joint, it's everything.
Yeah, maybe that'll be my next step.
I'm telling you, that sucker hurts.
But thanks for talking me off the ledge, because I'm telling you, like every time this pain pops up, it's like, it's my bladder. And then I'm like terrified to eat anything when, like, for the last 6 months, I've been eating tomatoes and everything, and I'm not bothered by whatever. And
well, if you can eat tomatoes and you're not bothered by it, your bladder wall's healthy.
Right.
It's your freaking muscles in your SI joint that are clearly the dominant problem. Right. And go to Amazon and get an SI belt and try it.
I will.
You know, that's one thing my physiatrist said to me very quickly is, are you using an SI belt? And I went, what the hell is that? And I went to a local surgical supply store and I put it on and all my pain went away.
Wow, that's
I was shocked.
I'll have to try that.
Yeah, they make big ones. I don't like the big ones. This is a very narrow one. It's like only 3 inches wide, and it's made by a company named Serola, Serola.
Okay.
Can you see that?
Yep, I see it.
Try it, because if it makes your pain go away, then it's definitely your SI. Okay.
Yep, and I definitely think it's nerve too. My PT's like, nerve pain is burning and stabbing, and it's very painful.
Yeah, and in Dr. Weiss's book, he just flat out says he thinks the vast majority of patients with pelvic floor dysfunction have compromised nerves.
Sure.
You know, and that dermatome following where those nerves go. And he says that, okay, come on now, in my magazine here, hold on a sec. Wait. I have a quote from the magazine that's at the printer right now. Let me find it real quick. Let me go here and, oh, you know what? I haven't even, here, hold on a sec. I got to find it because there's a really good quote in here that I think would help. Okay, hold on. There we go. All right. Is this it? Who was it? Okay, come on. I've got this memory flickering right in my brain. Okay. Oh, yeah. Okay, it was Curtis Nickel. Okay, hold on. Was it? Okay, I got to find this real quick. Okay, here we go. So this was Curtis Nickel, the top IC doctor in Canada, who just proposed 9 subtypes for IC. In his discussion of pelvic floor pain, patients demonstrating pelvic floor dysfunction, tension, or trigger points will benefit from therapies that target muscle health, including heat, stretching, relaxation, physical therapy, and the use of skeletal muscle relaxants. If pain is localized to one side or appears to follow nerve pathways, nerve blocks may be necessary. Pelvic floor Botox may also be helpful, though we did not use that in the clinic. Anyway, so there again, he's differentiating. He's saying if the pain is going to one side, we're always talking nerves. Okay? All right, hon. Carry hope in your heart. This is doable. And the blessing here is that you have a normal bladder. Let's celebrate that. You don't have to think you're going to suffer with an incurable bladder disease for the rest of your life. We don't need it. You have injury/trauma, just like I do.
Right.
Okay.
Thank you, Jill.
All right, hon. Nice talking with you. All right, I'm going to shut Zoom down now because a couple of people left. So we'll just go ahead and say goodbye. And I'm going to go back to Facebook and YouTube. All right. Okay. See you later.
Bye.
Okay, the Zoom meeting is done. Let me do this here. I lost here. Hold on. I got to do that. I don't even know how many people are still here. Oh, people are still here. Yay. Have I ever heard of, Sandra said, have I ever heard of black seed oil? No, I haven't. Michelle said, now this was some time ago. We were talking about the mesh issue. Yeah, mesh removal, just so you know, mesh removal is very difficult. It's because the mesh, think about a wire screen in your window, right? So there's a lot of shapes. And so a mesh, it's a mesh. It's like a sieve. And so what happens is that the tissue goes through all the little holes in the mesh. And so the mesh gets incorporated directly into the meat of the tissue. Thus, removing the mesh is very, very difficult. PK says, is pumpkin seed good for IC, or would you recommend bladder rest? Pumpkin seed, the first research study that I saw with pumpkin seed was at the American Urology Association meeting, I don't know, about 8 or 9 years ago. And it was within the context of dealing with chronic prostatitis. The pumpkin seed oil was found to be quite helpful for prostatitis. Of course, now we know that chronic prostatitis is a chronic pelvic pain syndrome, just like interstitial cystitis is a chronic pelvic pain syndrome. And so I don't see any harm in doing pumpkin seed oil. I love pumpkin myself. I don't have an IC pumpkin seed study. I can look. Hold on. Let me just take a quick look. Pumpkin seed, interstitial cystitis. Let's see if there's anything. No. Nope. Lori says, I hate my mesh, but it's a done deal. I have found the crazy movements irritate it or heavy lifting. Exactly. Yeah, because it's literally in the tissue that moves when you move. And so if it's tight in one area and you try to walk around it, it's going to be abrasive. It's going to pull. It's going to, meshes. It was a crime. It shouldn't. that early expose about mesh is just nothing short of disgraceful. That you had a company, and I don't remember the name of the company, and they've already been sued and they've already lost, but they thought that polypropylene mesh was the next greatest thing for repairing vaginal prolapse. And it turned out that the company that sold them the mesh said, don't use this in the human body. It's not meant to be used in the human body. And they blew them off and went to China and bought cheap mesh. And the documentary even tried to find the company in China that sold it to them. And it was this cheap storefront, grubby, grimy thing that sold them. And the pharmaceutical company here bought like a lifetime supply, like 100-year supply. And when they did the safety, quality, and data to compare the Chinese mesh with the American mesh, the Chinese mesh did not meet American standards, but they used it anyway. And millions of women, or hundreds of thousands of women, are paying a terrible price for that. It's really quite sad. Hitatsu said, my urinary incontinence was getting better, but suddenly I had an involuntary leak today in urgency. I ate a bit too much bitter dark chocolate. Well, of all the chocolates, dark chocolate is considered the safest, but it is provocative. Chocolate has irritants in it that are known for triggering migraines, bladder pain, headaches, etc. So carob would be better. And I would tell you, all the carob in our store is currently on sale, but I'm going to be taking it off of sale shortly. So if you want to try some of this fabulous coconut almond sea salt, mint carob candy bars, you name it, carob chips, we can eat carob and it's fine. It doesn't provoke symptoms or nerve pain at all, but like chocolate does. I love our carob so much so that I can't even have it in my house because I will inhale all of it. I will, every single time. Lori said salt is very irritating. Yeah, if you have a wound on your hand, would you pour salt in it? Of course. Putting salt into wounds was one of the earliest forms of torture. You know, flay somebody's back with a whip and then put salt on it. That's what they did, 1,000 years ago with all these, crazy wars in Europe and everywhere. Salt is provocative. It doesn't feel good at all. All right. Any other questions? Any other questions? If not, I am going to read the section on pain control in our book. Every meeting, I'm trying to read yet another section in our book, IC 101. How do you spell that chocolate candy? Carob, C-A-R-O-B, carob. And here, I'll just give you the link. I mean, listen, I'm telling you, the carob stuff that we have in the ICN shop is to die for good. Let me see if I can give you the link. Let's see if this works. Did that go anywhere? Let me check. Hold on. Did I get it right? Nope, I did not get it right. Here, let me get the right link for you. It's under food. Oh, and now I see. Yeah, it has a long URL. It's not quite that easy. Okay, try that link. That link will work. Let's see here. All right. So I am going to go through. So in every meeting, I have been reading sections of our book, IC 101. It's not just a bladder disease. And so we just ended with the discussion of pain care. So that's where I'm going to start with, and it's not too long, but it gets the point across. All right. The treatment of pain in the typical IC patient. Pelvic pain patients are suffering. While many turn to pain medication for help, it is important to also step back and ask your physician, what is triggering my pain? Is it the bladder wall, the pelvic floor muscles, pudendal neuralgia, genitourinary syndrome of menopause, fibroid tumors, endometriosis, a previous pelvic injury, pelvic congestion syndrome, a bad hip, Tarlov cysts? It is critically important that both the patient and the physician conduct a thorough evaluation of the pelvis and its various structures to address the source of the pain. In many cases, IC patients with severe pain have Hunner's lesions that with lesion-specific treatment can be reduced and eliminated. Many patients struggle with very tight pelvic floor muscles. Because physical therapy can be painful, some have turned to pain medication rather than working on rehabilitating their muscles. Yes, if you have tight pelvic floor muscles for years, also known as vaginismus, these muscles will probably be painful at first, but with time, attention, and dedication, muscles often respond beautifully to therapy, and many patients experience dramatic reductions in their pain. Some are effectively cured. The only exception to that are patients who might have a bony structure abnormality, such as a hip dysfunction, an SI joint, knees, or even feet, that is putting constant pressure and stress on the pelvic floor muscles. In these cases, orthopedic treatment may also be necessary. It's also important to focus on the location of the pain. Bladder pain is centered directly above the pubic bone. If you have pain to the left or right of center, or if the pain appears to be in a specific location every time, you must ask your doctor to study that location. What could it be? Scar tissue? A previous injury? The AUA guidelines for IC-BPS encourage compassionate and proactive pain care. They state that pain should be addressed at every doctor's visit and treated with a multimodal approach to therapy, including the use of the correct therapies, such as physical therapy, bladder treatments, to address the underlying problem, and if needed, opioid medications. If a urologist is uncomfortable or unwilling to provide pain meds, patients can request to see a pain specialist. Let me move this here real quick. All right, over-the-counter products. Palmitoyl ethanolamide. Palmitoyl ethanolamide, so known as PEA, has been studied extensively in Europe with a wide variety of chronic pain conditions with solid success. In 2019, the first ICPEA study was released by a team of Italian researchers who found it remarkably helpful at reducing pain in IC-BPS patients not responding to other therapies. At 3 months of use, roughly 86% of patients reported a significant reduction in their pain. At 6 months, 25% of these patients were pain-free. The remaining continued to have significant reductions. Piora is an entry-level PEA formula to support pain reduction in the bladder and pelvic region that is very similar to the formula used in the original study. Bladder Builder combines PEA with ingredients designed to support the bladder wall. And in a 1-year follow-up survey, 60% of Bladder Builder users reported an improvement in their pain levels, as well as fewer flares. And Allopath combines the soothing effect of aloe with the pain-reducing effect of PEA. These products are all produced by Natural Approach Nutrition. Okay, analgesics. A variety of over-the-counter pain medications are available, including aspirin, acetaminophen with Tylenol, or non-steroidal anti-inflammatory drugs, ibuprofen, ketoprofen, and naproxen. While these may not reduce severe pain, they may be effective for mild bladder and/or muscle pain, but moderation is essential. Aspirin and SAIDs can cause stomach irritation, allergic reactions, and potentially kidney damage, and are not recommended for patients with a history of allergies or pre-existing stomach conditions. In contrast, acetaminophen is more gentle to the stomach, but can cause liver damage or disease if used in excess. These medications should never be taken with alcohol. And we have a consumer alert. In 2015, a study from Korea found that the combination of antidepressants and NSAIDs have been linked to intracranial hemorrhage during the first 30 days of treatment, regardless of the type of NSAID used. Okay, opioid medications, the CDC guidelines. Opioid medications provide pain relief for the most critically ill and suffering patients. From end-of-life pain relief to sudden trauma and/or surgery, opioids can ease suffering. They have been safely and responsibly used by millions for a variety of legitimate purposes, including cancer care and, of course, IC-BPS. And for those who doubt that bladder pain can be intense, one study found that the pain of IC was equivalent to that experienced by cancer patients using the McGill pain scale. Bladder pain is characterized as relentless and difficult to ignore, making it difficult to perform even basic daily functions, much less sleep. Some IC patients may require more aggressive pain care with the help of mild to moderate opioid medications. But opioid medications have also been vilified. There is a thriving criminal industry manufacturing and importing highly addictive synthetic opioids from illegal labs in China. Drug dealers throughout the world push opioids, especially synthetically manufactured ones, because they more easily cause addiction and drive consumer purchases. Pharmaceutical manufacturers and distribution companies were also a significant part of the problem because they told physicians that opioid medications presented few risks. Opioids were aggressively marketed as being safe, effective, and appropriate for use in even minor pain. Physicians believed them and began prescribing them broadly. And this, of course, generated tremendous profit for these companies who distributed billions of pills. However, authorities were also able to determine that they overlooked glaringly obvious examples of misuse. Small town pharmacies were shipped millions of pills that were diverted to recreational and illegal use. They also hid early data that demonstrated that opioids did come with some risk. It was the development of extremely strong synthetic opioids, particularly fentanyl, that worsened the crisis that we are struggling with today. These very powerful medications create a much higher risk of addiction. Hundreds of thousands of young and old, famous or unknown, have overdosed, and the US government was forced to act. Numerous investigations were conducted, and pharmaceutical and distribution companies sued, shut down, and in some cases, owners and executives went to prison. Pharmacies were closed, and some medical care providers were prosecuted. And in these efforts, however, the chronic pain patient also became a tragic target. Chronic pain professionals and patient organizations were outraged when the Center for Disease Control guidelines for prescribing opioids for chronic pain were released without the participation of chronic pain experts on the committee. These, quote, rules, end quote, were quickly misinterpreted and implemented by a variety of institutions, such as Medicare, Medicaid, hospitals, and insurance companies, with a focus on denying and or discontinuing opioid medication use, and the results were devastating. Patients who were using medications responsibly in low doses prescribed by one clinician and with no sign of drug abuse were suddenly refused medication despite no evidence of improper use. Worse, patients requiring high levels of pain care or recovering from surgery were suddenly and inexplicably denied pain care. As a result, many patients were dismissed from their doctor's practices, refused additional prescriptions, and were forced back on disability because they were unable to work or function without some pain care. In 2019, the Center for Disease Control acknowledged in an article in the New England Journal of Medicine that some policies have been inconsistently applied and go beyond their recommendations, including sudden opioid discontinuation or the dismissal of patients from their physician's practice. They also said that, Nicole, hold on, I'll get to that, okay? They also said that the guidelines were never meant to be applied to patients struggling with cancer pain, surgical procedures, or acute sickle cell crises. They admit that the guidelines have been improperly implemented and they need policies which will allow clinicians to make clinical decisions based upon a patient's unique situation. They are concerned with physicians who are using the guidelines to justify abruptly stopping opioid prescriptions or coverage, particularly without weighing the pros and cons in patients who require and are successfully using higher dosages. Thus, IC patients have found it much harder to get pain care. We, the IC patient community, must be cautious, proactive, and responsible. Care providers are on high alert for patients who might be drug addicts. Don't be offended if you were asked to sign and fulfill a pain contract. These verify that patients are using medications safely. And patients who use medications in low doses responsibly and prescribed by only one physician are considered the best risk. In contrast, patients who visit a variety of doctors seeking pain medication may be refused. It is also important to note that opioid pain medications are now tracked carefully by various state and national drug enforcement agencies. Okay, so proactive pain care. Treating pain is like fighting a fire. If you catch it earlier, it will be easier to treat. If you let it worsen, more medication may be needed. Clearly, with restrictions on pain medication now available, every patient must avoid painful triggers and, when necessary, act early and quickly. This is hard for those who believe that using pain medicine is wrong. They will wait until they're sobbing in pain to use their medication. Pain is not shameful, nor should you be embarrassed. It's okay to ask for help, to ask questions about the right medications for you and how to use them correctly. And there are many different types of opioid pain medication, including short-acting, long-acting, and time-release. Some are used orally, while others are used as patches or as rectal suppositories. Short-acting opioid medications act quickly and will provide pain relief only for a few hours. These are the first medications usually suggested, especially after a painful procedure or surgery, such as a hydrodistension. This includes Percodan, Percocet, Vicodin, and Lortab. Long-acting opioids are Demerol, Methadone, and Belladonna, opium and rectal suppositories. And these can provide relief for prostate and urethral spasm, but rarely belladonna can over-relax the bladder, causing pain and an inability to empty the bladder. Duragesic transdermal patches offer a small, steady, slow release of medicine, and morphine pumps deliver intrathecal morphine in a small, steady, slow release. These implantable pumps are considered for patients with severe intractable pain. Now, cannabinoids. Cannabinoids offer antispasmodic, anti-inflammatory, and analgesic properties. Researchers and clinicians have had positive feedback from patients who have tried medical marijuana. These patients report less frequency, urgency, and pain, as well as better sleep, along with other comforting benefits. Patients who must take opioids may be able to take a lower dosage of their medication because marijuana enhances the effect of opioids. Other patients may be able to replace their opioids with medical marijuana. To better understand which cannabinoids may help IC-BPS patients, the different strains of the plant need to be further investigated. Though medical marijuana continues to remain illegal in some states, CBD derived from hemp is legal and available in every state, as well as online at major retailers such as Walmart and Target. Cannabinoids with tetrahydrocannabinol, THC, have psychoactive high effects and interact with the cannabinoid receptors to address the inflammation and neuropathic pain of IC. The cannabinoids with THC work best to calm bladder spasms. CBD, which does not have psychoactive effects, also has a calming effect on bladder spasms, just not as much as THC. Both CBD and THC affect the central and peripheral nerves involved in IC. Cannabis can be taken in many different forms. Most often it's edibles. Smoking or vaping cannabis can lead to more bladder irritation because of the byproducts associated with heat and combustion. CBD topical creams are also available. Patients who wish to try oral CBD oil should be aware of any irritating inactive ingredients, and CBD in topical form is possibly a safer choice. In the future, we may even have CBD bladder installations. Those were actually being studied in Detroit years ago. We do have a consumer alert. When purchasing medical marijuana, always ask for test results from the manufacturer to verify that it has not been contaminated with pesticides. Even products labeled as organic have been found to contain pesticides. If testing of data is not available, consider another product line that has done their due diligence to prove that their products are safe. And so this was a transcript from IC 101. It's not just a bladder disease. And you can get much more information on pain through Breaking Through Chronic Pelvic Pain, as well as a variety of other books that are listed here. All right. So anyway, Nicole says, here, hold on. I've got to clean up my desktop here. Do you go over the mesh sling complications and mesh removal or anything like that? I had my bladder prolapse again, and it bled so bad I had to have 2 blood transfusions. Wow, girl. it's mesh sling complications are profound. Mesh can migrate through tissue. It can migrate through blood vessels. It can migrate through the urethra. It can migrate through the bladder. It can migrate in many different locations, even the rectum. And so that's why if you have a prolapse, most doctors are not using mesh. Supposedly they've developed some better forms of mesh, but it's a very delicate conversation you have to have with your doctor. If they are considering using mesh, you need to identify the brand name and do your due diligence and do some research to see if there's any complications with that mesh. Preferably, they try to use your own tissue instead rather than mesh, especially for prolapses. Removing mesh is incredibly difficult, and some would say in some patients impossible. It is a devastating surgery that can have long-term complications, not only in damage to the tissue and them having to cut the mesh out, but also a recurrence of the prolapse. So again, it's a very, everybody thought that mesh was going to be the great savior, and now we know that mesh has been a tragic episode in gynecological history. Nicole said, that's where I'm at. I need removal. I have symptoms of MS, memory issues, and tremors. I don't know if that's related to mesh, Nicole, but you know, think about breast implants and leaking breast implants. Patients who have leaking breast implants develop a number of autoimmune issues, and as their body's trying to fight the silicone or whatever is leaking into their body. You know, foreign objects in our body are not meant to be there, and our body is definitely going to react. It's going to put scar tissue around it. It's going to try to push it out of the body potentially. I don't know if memory issues and tremors are related to that, but I have essential tremor. You can see it often when I start meetings. I get this tremor, right? My head will do that more than anything else. I also get tremors in my fingers sometimes. If I do a lot of yard work, then my fingers will shake a little bit for a little bit afterwards. So, all right, guys. Well, listen, last call for questions. Last call for questions. Any more questions? I feel like I kind of rambled today. I'm sorry about that if I did. Last call for questions. Last call for questions. Otherwise, I hope that you have a wonderful evening. I hope that you have a great week, and hopefully I'll see y'all again next Sunday. And for Facebook, maybe even on Thursday or Friday. And if you find these meetings helpful, or you can come on over to the IC Network, sign up for our newsletter. You can become a member and get our magazine, The IC Optimist. We also have a shop where we sell heating pads, chair cushions, and things like that, just to make it easier for you, because there are certain things that can be helpful, like if you have pudendal neuralgia, a chair cushion, right? So we got some really good chair cushions.